ماشي. السلام عليكم دكتور خالد، حضرتك عامل ايه؟ دكتور خالد، احنا عندنا شير سكرين ايكون تحت اللي هي الخضراء. تمام، بسم الله الرحمن الرحيم. اليوم من مستشفى السعودي الألماني فرع الرياض بنبدأ فعاليات اليوم الثالث والأخير للمؤتمر السادس للأمراض الباطنة. Welcome everyone. I have the honor to start the third day and the last day of our internal medicine webinar, the sixth. And we are happy to have Dr. Khalid Al-Mohsen. Dr. Khalid Al-Mohsen is always generous with us and is coming every year since the beginning. And Dr. Khalid Al-Mohsen, he chose very interesting presentations. The first one will be about lupus nephritis, and second one will be about resistant hypertension. Dr. Khalid is our eminent speaker since the beginning. He is consultant nephrology, and he is the head of nephrology department in King Fahd Medical City. Dr. Khalid, you may start and share your screen. And thanks for being with us.
Assalamu alaikum, shukran, Dr. Ahmed, and thank you for this nice introduction. Also, I'd like to thank the organizing committee at Saudi German Hospital. It's my pleasure always to be here. I hope my slides is clear now.
Yes, everything is clear.
Okay.
I can hear your voice very well, and the presentation is present as full screen.
Okay. So I will start now. Bismillah ar-Rahman ar-Rahim. Good evening, everyone. I will start my presentation about the disclosure. I have no conflict of interest. These are the outlines of my presentation today. I'll talk about definition, pathology, impact, and the treatment introduction. So regarding the introduction, just to know about the lupus. So in 19th centuries, the lupus erythematosus was introduced as just described skin lesions, and the disease was not known at that time. And after 100 years later, it became known as a systemic and spares no organs. So it involved many organs in the body. So in 1941, a group of scientists described systemic lupus as one of the connective tissue diseases. If we look at the definition, so it's an autoimmune disease in which organs and cells undergo damage initially mediated by tissue-binding autoantibodies and immune complexes. To focus about the lupus nephritis per se, so it's histological evident in most patients with SLE, so it's not a rare condition, and it's almost prevalent around 50 to 60% in patients with SLE. It's considered to be one of the most serious manifestations of SLE, and usually it takes 5 years to appear after the diagnosis of SLE to manifest as lupus nephritis. Although it's not necessary that we will have SLE manifestation, we can have an lupus nephritis alone without other systems to be involved. So what's the disease impact? So during the 90s, 50s, the 5-year survival rate among patients with lupus nephritis was almost close to zero. So it is really serious condition. It is fatal with increased mortality. But after introducing the new treatments like cyclophosphamide and other immunosuppressive therapy, actually this made a good improvement in the disease outcome. So the 5 and 10-year survival rate were higher as 85% and 73% respectively. And the most common cause of death is cardiac and infectious diseases. How about, this is in general, how about the renal related disease? So of those patients who progress to develop end-stage renal disease and they become dialysis dependent. If you look at dialysis per se, what's the prognosis overall? This is the prognosis of dialysis, and you can see here the 5-year survival rate is around 60%, and it is higher even than some cancers like stomach cancer, esophageal cancer, lung cancer. So this is a really serious disease that we have to take care of earlier, and we have to treat aggressively. If we look at the causes or the risk factors, we can see this is a famous paper which was published in New England, and you can see the different factors that can contribute to the inciting the immune or autoimmune disease, like genetics, environmental factors, immune regulator, hormonal, and epigenetics. And once we have this autoimmune process triggered, then it can involve different systems like kidney, skin, lung, brain, heart, and others. Here's just in this table, you can see that there are many genetic factors has been identified so far. And there's still this list, you can see it on the right side, is still like expanding and going up. And actually we are doing ourselves a study about genetics, and I hope that we will be able to identify local genetics in our area, which also might help to identify resistant genes, which will help to improve the treatment options. If you look at the environmental factors, one of them is the ultraviolet light, the virus, smoking, alcohol, silica, and dust. All of these, so that's why, for example, we have to apply sunscreen for some patient to avoid relapse. If we look at the clinical presentation, if we talk about lupus nephritis per se, we can have different symptoms or signs, including proteinuria, which is 100% in patients who have lupus nephritis, they will have proteinuria. We can have microhematuria, which is 80%, and renal impairment, it ranges between 40 to 80%. Those red or highlighted in red are the most common ones that we see, but we can see others like, for example, nephrotic proteinuria, which is around 65%, RBGN, which is rare, hypertension, and tubular abnormalities also, it can be there. So we know the clinical presentation. How about the laboratory test? The usual kidney function, the renal profile, and we can send also for 24-hour, or we can send now the spot urine test for protein creatinine ratio, which is validated recently to be equivalent and can be helpful if we cannot do the 24-hour urine collection. How about the other laboratory test? We can do ANA, and it's not specific for lupus nephritis. It's mainly for diagnosis of SLE. We can do the anti-double strand DNA, which will be increased in this case, complement like C3, C4, or CH50, which will be decreased. ESR will be high, but again, this is not related to lupus nephritis per se, but for SLE, C-reactive protein will not be changed. And the anti-C1q antibodies, it's not available everywhere, but it can be done as peripheral blood test, and it can, if it's increased, it will indicate lupus nephritis, but we have to mention that it's not sensitive as anti-double strand DNA, but it is more specific to the kidney more than the other. The gold standard, to diagnose lupus nephritis, if we have suspicious features like we have symptoms, we have the abnormal labs, the proteinuria, and that we want to do kidney biopsy to confirm it. And actually, the importance of having kidney biopsies for a few things. First thing is that we have to confirm the diagnosis. We can classify the class of the lupus nephritis. We can quantify how much damage and how much we can go further with treatment. So we have different classification criteria. We have the International Society of Nephrology, which have classification. And usually, I will show you in the next slide about the different histological manifestation. But if I talk about the immunoglobulins, it's IgG, but we can have also the other immunoglobulins available like IgA and IgM. We can have C1q, C3, and the others, so we call it full house pattern. If we have a strong glomerular C1q staining, it's also suggestive of lupus nephritis. And in addition, that tubular reticular inclusions are thought to be reflect high interferon, and it's not specific to lupus nephritis, but it might be indicative and can help differentiate between primary and secondary lupus nephritis or membranous nephropathy. The classification, we have 6 classes of lupus nephritis, and each one of them carry an importance to know it, so it will reflect on the management itself. So we have class 1, where we'll have minimal mesangial lupus nephritis. Then class 2, we have mesangial proliferative lupus nephritis. Class 3, we have focal lupus nephritis, where less than 50% of glomeruli are affected. Class 4, which is diffuse lupus nephritis, where it's more than 50% of glomeruli is affected. Class 5, which is membranous, and class 6, when we have advanced sclerosing lupus nephritis, which is more than 90%. In this case, it's in this stage, there's no point of treatment. And we'll talk about the management for each type. In general, if the goal of treatment in lupus nephritis is we want to normalize the renal function or at least to prevent progression or progressive loss of renal function. And the therapy depend on the pathological lesions that we found. And it's important not to forget the extrarenal manifestation, because also they help to decide what type of treatment we want to give. We have different type of regimens or classes. So we have the adjunctive treatments, we have the primary disease management by immunosuppressive agent, and this is divided into induction and maintenance, and we have the lifestyle changes. If you talk about the adjunctive treatment, we have the hydroxychloroquine, which is well-known older drug as anti-malarial, but they found an interesting characteristic of it as anti-inflammatory medication, and it was tried in lupus nephritis, and it helped to reduce or lower the rates of flare and reduce the readmission, reduce the renal damage, and it has less clotting events on patients who used it. The ACE and ARB, they are important for management of blood pressure, and especially for patients with proteinuria, it will reduce the proteinuria by 30% and delays the doubling of serum creatinine, and also delay the progression to end stage. Other antihypertensive treatment are important to control the blood pressure and delay the progress of renal disease. Statin therapy is an important factor for patients who have high LDL. Calcium supplement is important also for the bone protection if we are in long-term use of corticosteroid therapy. So we talked about the anti-malaria treatment. So this is, we have different study indicating the importance, and they are really showing significant effect in all the classes of lupus nephritis. And it's an important adjunctive therapy to be added unless there is contraindication or the patient develops side effects like retinal pigmentation or skin pigmentation, then we have to stop this important drug. Here in this table is just showing that here the different classes and when to start therapy. And actually in class 1 and 2, we don't have to give immunosuppressive therapy. We might just need to give antihypertensive if needed and there is a proteinuria. Otherwise, these two classes are mild and no need for treatment. Class 3 and class 4, we have to start the immunosuppressive medication in addition to the adjunctive therapy. If we want to say easily that although that class 4 is more aggressive disease, but it responds very well to the treatment. If we say class 3 is less aggressive, but it's more stubborn, you need to give, you have to give longer time for medication. For class 5, we can use a steroid plus CNI, we can use Silsipt or other medication. Class 6, as we mentioned, is in the stage, so there is no room for therapy at this stage. If we look at the induction phase and what are the recommendations for the induction phase, we have the KDIGO guidelines, which was just published recently. And the recommendation is that we have to give pulse methylprednisolone for 3 days. Then we have to give oral prednisone and taper it slowly by the end of 3 months. Plus, we have to give the other immunosuppressive agent. We can give IV cyclophosphamide, and they recommend the Euro-Lupus protocol, as you can see, 500 milligram Q2 weekly for 6 doses, or the MMF 2 to 3 grams for 6 months. The European guidelines have similar recommendation for a pulse steroid or IV steroid. Then we'll give oral. But you can see here they have lower dose of oral prednisone more than the KDIGO. Then you give the other immunosuppressive agent. But they added here a third arm that you can also use multi-target therapy as a choice for induction, especially for patients who have, for example, severe proteinuria and they have normal creatinine. You are not worried about the CNI will affect the GFR. The maintenance phase, we have the protocol from the KDIGO recommendation. So the target is that you want to taper prednisone to less than 10 milligram per day. and you can give MMF, which is the first choice. If patient is pregnant or have a contraindication, you can give Imuran as alternative. The European guidelines, if you see here, they recommended the oral steroid actually to be lower than the KDIGO. And I agree with that. And in different studies, they found that patient who has lower dose of steroid as maintenance, they did better actually, and they have less side effect and complication with similar renal outcomes. And in combination with MMF or Imuran as indicated, but you can see here the dose is higher a little bit in the European recommendation more than the KDIGO guidelines. Here's just a trial summary of the evidence that we have so far in lupus nephritis management. And you can see here different trials and different agent. And if you can see here, the complete renal response percentage is here in this column. What you can see here that we don't have something 100% or close to 100 even, which indicate that this is aggressive disease. Yet we don't have the drug which will have a cure or complete renal response. So this drive the need to develop new medication or try different combination to achieve better complete response. Here is just in this slide, I'm showing you the difference of the comparison between the old standard, the MMF and cyclophosphamide treatment for the management of lupus nephritis in both classes 3 and 4. And we have different guidelines recommending, for example, the NIH Eurolupus indicating different regimen and show they are equivalent. The only things that we are worried about the cyclophosphamide is the side effect that is known to all of us in terms of infections and infertility. And MMF seems to be a good agent for induction, and it's one now of the standard of care for an induction therapy. The new trials, just a summary of the recently published trials. Here you can see here the eptinezumab from Nobility trial. It's targeting CD20, and it works by B-cell depletion, and we have positive outcome. We have the belimumab and voclosporin, which is a calcineurin inhibitor. I'll talk about each one of them in details. So when we choose, this is just highlights about the importance of choosing the immunosuppressive agent. So we have to choose something which has less side effect, that prevent flares, and get the induction as we wanted, also improve the quality of life and survival. So when we choose the B-cell depletion, we have different types of agents. We have agent that deplete the B-cells like rituximab, eptinezumab, or ifinatamab, or that prevent activation like the belimumab agent. If we look here about rituximab, which is being introduced in different study in lupus nephritis, we can see here that we have the Explorer trial and the Lunar trial. Both of them, they were randomized controlled trial, and unfortunately, they did not show a benefit in lupus nephritis patient. We have the observational study, the Rituximab. It was observational. They included only 50 patients. There was improved or signal for good outcome. So if we want to see the use of the benefit of rituximab in lupus nephritis, yet is not established. Although in Lunar trial, when they did a subgroup analysis for those patients, and they looked at patients who have a complete depletion of CD20, they found a better outcome on those patients in comparison patients who did not deplete their CD20. So this might give a hint that maybe there is a room for rituximab in lupus nephritis patient, and we can use it now currently in patients who fail to respond to the other treatment or they have refractory disease. So, how about the belimumab? We have the famous trial, the BLISS lupus nephritis, which they in this study they introduced belimumab. They compare it to the standard therapy. So this is a double-blind RCT. They included almost 450 patients. They include the patient with the class 3 and 4, with GFR above 30. And actually what they give belimumab plus the standard of care versus a placebo, where they receive the standard of care alone. And they followed the patient for 104 weeks. And when they looked at the complete renal response in comparison between the two groups, we can see here in the belimumab group that they have a complete renal response 30% in comparison to 20% in the placebo. And this is with odds ratio of 1.7 response, which shows improvement, or there is a good response in those patients who receive the belimumab in comparison to people who receive the placebo. But if we look at the partial renal response, there was no big difference. If we look here, the confidence interval crossed the unity, so it was not established to have an effect as partial renal response. But we have a good complete renal response with belimumab agent. And just this figure just to show the graph here between the complete renal response over time and the probability of complete renal response in two groups. Here it can show the difference between belimumab and the placebo. If we look at the nobility trial, which is we look at the phase 2, actually they gave optimizumab plus MMF in comparison to MMF alone. And they followed the patient for 104 weeks. And here we can just see it here. They gave 100 milligram. They give it as day 1 and day 15. Then at 6 months, they included patient with a class 3 and 4, and with urine protein creatinine more than 1 on 24-hour urine collection, and they excluded patients with RBGN or if they have severe impairment in AGFR. The primary endpoint, they were looking at the complete renal response at 52 weeks, and the secondary point, they were looking at the overall renal response and the changes in the complement and the double-strand DNA. If we look here at the result of this study about the renal response, the complete renal response, maybe at 52 weeks, there's a signal for better improvement or good complete renal response. But if we look at the p-value here, it's not statistically significant. But after 76 weeks, the group of the intervention or the optimizumab, they did better than those on placebo. If we look at the overall response, we can see here on both at 52 weeks and 72 weeks, patients who received the optimizumab plus the MMF, they did better than MMF alone. This is the complete renal response over time. We can see it here. They did better at 76 weeks, as I mentioned before. The laboratory changes, you can see here, there's improvement in complement. The anti-double strand has decreased, and also the urine protein, it was lowered in comparison to the placebo group. Safety profile, there was no significant difference between the two groups, the optimizumab and the placebo group. How about the B cell depletion, which is important? We can see here the good thing that this drug is able to reduce or deplete the B cells very fast in 2 weeks, and it was maintained for a very long time when it is compared to the usual rituximab. So this is maybe an added benefit. Just to mention that maybe, yes, it shows superiority, but still the drug, it's not used alone, so we have to use it in combination with our medication. The other thing is that the cost maybe is high, so maybe it's not affordable to all patients, but it can be used for patients who have refractory or severe aggressive disease in certain selective patient. How about voclosporin, which is CNI or calcium urine inhibitor? So this drug, we have different trials. We have this is the phase 2 randomized controlled trial, where they compare the efficacy and safety of 2 dosing of voclosporin with a placebo to achieve remission. So they included almost 265 patients with class 3 and 4, and they gave them the standard of care MMF and steroid, and they randomized them into the standard of care a low dose 23.7 milligram of voclosporin and 39 milligram dose. And they looked at the primary endpoint, which is the complete renal response. We can see here that in both group, it was significant in comparison to placebo. And when they look at the secondary endpoint after 12 months, also that it shows that the voclosporin, the low dose, especially, you can see here, the patient who are on lower dose, they did better in terms of response in comparison to the placebo or even to the higher dose. Then they did the Aurora trial, which is the phase 3 trial. They followed patient for 52 weeks, and they give them only the low dose voclosporin. They compared them to the placebo. And they followed them for 52 weeks. And when they looked at the primary endpoint at 52 weeks, gangrene response, you can see here that the odds ratio for this, the patient who received the drug, they have 2.65 odds ratio to achieve the renal response in comparison to the placebo group. And it's shown here that the response was 40% in comparison to 22%, and it was clinically statistically significant. This is just the some of the ongoing trials. Some of them are released already, like the Aurora and the Nobility. Some of them are still ongoing. Again, this indicates the need for a better drug, that we need to achieve remission with something that will be maintained for a very long time and has less side effect with affordable price. Just want to show you at the end that what are the renal response measures that when we follow. So when we say complete renal response by the KDIGO definition, return of serum creatine to previous baseline plus a decline in urine protein creatine ratio less than 500 milligram per gram. The partial response is the stabilization plus minus 25% or improvement of serum creatine, but not to normal, plus more than 50% decrease in the urine protein. Deterioration is a sustained 25% increase in the serum creatine. If you look at the ACR definition, so they have different names. So they're called improvement when there's 25% increase in GFR, or there's more than 50% reduction in urinary protein. They divide it into partial and complete. And the urine sediment, there should be no active urine sediments in the urine. The other classification is not improved and worsening. So the worsening is 50% or more worsening of proteinuria or serum creatinine. Just these important definitions to know when you judge, you need to continue with your treatment, you need to change it, you need to upgrade it, or the patient is in remission and you need to stop or taper down your therapy. By this, I will conclude my presentation, and thank you so much.
Thank you, Dr. Khalid. It was really amazing information and updated, especially with KDIGO guidelines that was recently updated. And your presentation has attracted some questions. Let's start with the first question. If the patient is candidate for transplantation, how long you will keep the patient inactive or in remission till you put him on transplantation?
So, of course, if patient is having lupus nephritis and reach stage 5, and they are ready for transplant, they can go. You don't have to wait. Of course, they will receive inductive therapy for transplant, and this will control the disease. If we're talking about extrarenal manifestation of active disease, it depends what are the system or which system is involved. If you're talking about carditis or cerebritis, yeah, of course, the patient has to be in remission before they are subjected to a major surgery like transplant. But for renal or lupus nephritis, once they are in the stage and candidate for transplant, you can proceed at any time. There is the theory before that says the uremia or patient being on dialysis, the dialysis or the uremia will kill the lupus, and it's not. There is no specific like number of years. For example, there are some studies say that 5 years of being on renal disease, on dialysis will kill the lupus, but actually we don't have a strong evidence indicating that.
I agree with you. Previously, I was working in Egypt, and we have a student hospital for Ain Shams University Hospital. And in student hospital, we have some cases of lupus. And at that time, more than 15 years ago, there was a concept to leave the patient on dialysis for 1 year. And I think one professor studied the complement levels and some anti-DNA titer or something like this, and he proved it. But I think this was not enough to be a guideline. So I believe the same, because I researched about this. I didn't find any recommendation to keep the patient for how many months or how many years on dialysis. Once in the stage, he's candidate for transplantation. This is your opinion, right?
Yes.
Yes. Okay, I agree with you. You mentioned that we are currently looking for genetic samples for the patient with lupus to see if we have here genetic background for the Middle East or Saudi population, right?
Yes.
Is there any way to refer cases to your center or something like this?
We'll be happy. I mean, if there's patient who's actually we almost completed the trial, but we're looking for patients who have resistant pattern. Now we're still collecting those patients. For patients who have response to the usual treatment, we completed our sample, but we are more than happy to communicate with me anytime to enroll them in this study, inshallah.
Okay, I think I will send you some patient. Also, I have one question myself. I have one patient who was on Cellcept, mycophenolate mofetil before, and she suffered from 2 attacks of pancreatitis, severe attack, okay? And we have no obvious etiology for pancreatitis except being on Cellcept. And once Cellcept was stopped, she recovered over the next few weeks. So Imuran is not controlling her disease activity. And as you mentioned before, rituximab was not enough. By the way, her renal biopsy is stage 4. And rituximab, we don't have strong evidence for its use in induction, okay? So what to do with this patient? To start with CNI?
Yeah, it depends now, like if we have normal renal, kidney function or creatinine is elevated. So CNI in patients with have high creatinine, I would not use it because it might impair it, make it worse, especially in acute like stage. Although it can be used in multi-target therapy, mainly if the patient has significant proteinuria. For Imuran, I would be a little bit reluctant because it also can induce pancreatitis, maybe more common than the MMF. So yeah, it's a tight situation. The other options that what you can use, for example, is myfortic different than MMF in terms of pancreatitis? This is something we have to look at. Second thing, rituximab. Yes, in this situation, I would say rituximab is indicated in this situation because we have no options to be used. The other part, we can go all this like practice, and we can use cyclophosphamide as monthly dose, like before. As you know, that the induction before was cyclophosphamide plus monthly doses for like what we were. It was abandoned because of the toxicity and large accumulative dose. But in situation like this, if I cannot go with this, I might go back to cyclophosphamide again if I'm out of option.
So cyclophosphamide, then as induction, then for maintenance, it's better to keep her on myfortic, like mycophenolate sodium, just to see what is going on.
Yes.
And we will pray that she will not suffer from pancreatitis.
Yes. Inshallah.
Okay. I agree with you. This case was referred to us, and we referred the whole case to Mayo Clinic. And their opinion was to start with cyclophosphamide, the same like you advised, and as an induction. And currently she's well controlled, and we are still in the 6 weeks. In the we will give the third dose, I think, after 3 to 5 days. I will keep you updated about this case. Okay.
Thank you.
Now we have Dr. Muhammad Al-Khwaiter, our nephrology consultant, and he is nephrology consultant in King Khalid University Hospital. Dr. Al-Khwaiter, thanks for joining us. We have two presentations for Dr. Muhammad Al-Khwaiter. The first one is nephrology or renal outcomes in diabetes, and the second one will be membranous nephropathy. We will start with the first one, then we will go back to Dr. Khalid Al-Mohsen for an interesting presentation about resistant hypertension. The screen is yours, Dr. Khwaiter, and thanks for joining us.
السلام عليكم ورحمة الله وبركاته. بسم الله الحمد لله والصلاة والسلام على رسول الله. أول شيء, thank you so much, the organizing committee, for inviting me. It's an honor to be with you today. I am Hamd Al-Khwaiter, consultant nephrologist from King Saud University Medical City. I'm going to talk today, inshallah, about the renal outcomes in diabetes. The outline of my talk, I'm going to talk about the outcomes in terms of end-stage renal disease, doubling creatinine, and worsening GFR, as well as worsening albuminuria. But as we all know, these are not very solid, outcomes when it comes to mortality and cardiovascular events. So my focus today is about the renal outcomes. However, I will actually speak about the mortality and cardiovascular events in the studies of renal outcomes and cardiovascular outcomes. I'm not going to talk about the cardiovascular outcomes separately. No, I'll talk about it in the context of renal outcomes. So we'll touch base on how glycemic control would affect the renal outcomes, the blood pressure control as well, the use of ACE or ARBs, the use of SGLT2 inhibitors, the use of a glucagon-like peptide-1 analog, and the most recent trials about the use of phenrenone as a non-steroidal mineralocorticoid receptors antagonist. So I'll start with the first point. Do we have an evidence saying that good or intensive glycemic control will halt the kidney progression or will improve the proteinuria? Well, we have this study that was published back in 1993, where they tested type 1 diabetic patients against intensive glycemic control versus more liberal kind of or conventional kind of control. The A1C that was achieved in the intensive group was 7.3%, while the one in the conventional group was 9.1%. The follow-up was for 6.5 years, and they found that actually that the intensive therapy reduced the occurrence of microalbuminuria by 39%, and also decreased the albuminuria by 54%. Okay. Do we have a long-term kind of follow-up for this particular study? Yes, actually, and it was published in 2011. It showed actually that the tight glycemic control has significant impact on the halting the progression of the kidney disease. The GFR in those patients who actually have better glycemic control did have better and higher GFR in comparison with the conventional group. So I would say we have good evidence, good quality of evidence stating that good and intensive glycemic control would actually have a good impact on the kidney function on the long term and albuminuria on the short term. Having said that, as we all know, we are clinician, we have to individualize our patients. Patients who develop, frail patients who develop hypoglycemia frequently, we will not be so much intense when it comes to the glycemic control, as he may die from hypoglycemic bad hypoglycemic events. But this is the general rule. Let's target a good glycemic control for diabetic patients in order to protect the kidney. Okay. How about the high blood pressure? Well, the high blood pressure in the context of diabetes, we have the MDRD study that was published in New England in 1994. And actually, there are two arms, as we know. The first arm, they were trying to achieve a blood pressure target of 140/90. And the target blood pressure for the second group was 125/75. And there was actually a slower progression of chronic kidney disease in the intensive group when the proteinuria is more than 1 gram. But when the proteinuria is less than 1 gram, there was no actually significant difference between the two groups. Any other trials about high blood pressure in the context of diabetes? Yes, we have the ABCD trial that was published in 2002. It is a randomized controlled trial in normotensive patients with type 2 diabetes mellitus. And they randomized the patients into two arms. The first one, intensive kind of blood pressure control, as they were targeting 10 millimeters below the baseline of the diastolic blood pressure, versus the moderate kind of control of the diastolic blood pressure with 80 to 89 millimeter mercury. Those patients who have this blood pressure, the 80 to 89, they actually gave them placebo, while the patients randomized in intensive therapy, they received either a calcium channel blocker or enalapril. So again, normotensive patients, it's an RCT. They randomized them into two groups: intensive therapy group, where they're targeting a diastolic blood pressure of less than 10 millimeter mercury, or the moderate control of the blood pressure with a diastolic blood pressure between 80 and 89. They randomized the two groups into the placebo for the moderate control, and for the intensive control, they subsequently randomized them into either enalapril or calcium channel blocker. So the primary endpoint was evaluated was the change in the creatinine clearance. Okay, and the secondary outcomes was about albuminuria and retinopathy, in addition to the cardiovascular events. They followed them for 5 years almost, and the target mean blood pressure that was achieved in the intensive group was 128/75, while in the moderate group, the mean blood pressure achieved was 137/81. And there was no difference between them in terms of creatinine clearance in 5 years' time. However, lower percentage of patients in the intensive group progressed from normal albuminuria to microalbuminuria, and from microalbuminuria to overt albuminuria. In addition, the intensive blood pressure control group also demonstrated less progression of diabetic retinopathy, a lower incidence of stroke. And there was, equal between the enalapril and calcium channel blocker groups. So in this study, the intensive kind of blood pressure control resulted in improvement in the albuminuria, okay, in addition to retinopathy. However, it didn't show any significant difference in the creatinine clearance. Was the study too short to demonstrate a renal or GFR benefits? That's one of the possibilities. All right, so let's now move to the third point that talks about the use of ACE in type 1 diabetes mellitus. As we all know, ACE is very well studied in type 1 diabetes, while ARB was very well studied in type 2 diabetes, but we use them interchangeably between the two groups, actually. So ACE in type 1 diabetes. I'm not going to talk about all the studies, but I'll talk about the landmark studies in the field. We know the captopril study in 1993. They looked at around 400 patients with proteinuria of more than 500 milligram, serum creatinine of less than 220, and they assigned them to either captopril or placebo. Okay, if they need, they gave them other antihypertensive therapy on top, excluding calcium channel blocker. And at 3 years' time, they found that there is a better actually impact with the captopril group in terms of rate of death and end-stage renal disease, and in terms of the likelihood of doubling serum creatinine. And also it slowed the annual loss of creatinine clearance. So there was a positive study favoring the use of ACE inhibitors in type 1 diabetes mellitus versus placebo. Do we have any other evidence? Yes, we have the MicroHope trial, and the MicroHope trial was a larger study, 3,600 patients. They followed them for 4.5 years, and they include diabetic patients with, so high risk kind of diabetic patients, more than 55 years old, and they have cardiovascular events. Okay, in addition to having one or more cardiovascular risk factors. So what was the result of the study? So among patients with diabetes at high risk of cardiovascular events, the treatment actually with ramipril, the treatment with ramipril lowered the incidence of development of macroalbuminuria in comparison with the placebo. Is this a solid kind of outcome? Well, it's a surrogate for renal improvement, but as we all know, it is not a solid outcome. The solid outcome is usually cardiovascular events or doubling serum creatinine or end-stage renal disease. Okay, anyway, it was positive. We believe that the microalbuminuria, improving the albuminuria on long run, will protect the kidney from deterioration, or at least slow the progression of deterioration. How about ARBs in type 2 diabetes mellitus? We have the INDT trial that used irbesartan. That's why irbesartan, we use it a lot. Personally, I use it. It's my favorite in patients with diabetic nephropathy of type 2 diabetes. 1,700 patients with type 2 and high blood pressure, as well as significant proteinuria of more than 0.9 gram per day, and moderate chronic kidney disease. They were randomly assigned to irbesartan, amlodipine, or placebo. So we have 3 arms here: irbesartan, amlodipine, or placebo. And the systolic blood pressure was less than 135 or 10 millimeters lower than the baseline. The target diastolic blood pressure was less than 85. Relatively short term trial at 2.5 years, they found that the likelihood of doubling serum creatinine was lower with irbesartan compared with amlodipine and placebo, even though the blood pressure in irbesartan and amlodipine groups were similar. So despite that you have similar blood pressure control in the irbesartan group and the amlodipine group, irbesartan was better in terms of lowering the possibility and the likelihood of doubling serum creatinine. There was a trend, but was not significant, toward lower incidence of end-stage renal disease with irbesartan as well. However, there was no difference in terms of cardiovascular death or cardiovascular events. That's actually the irbesartan. So lower incidence or likelihood of doubling serum creatinine in comparison with amlodipine and placebo. Okay. Any other trials? Yeah, we have renal trial, and the renal trial actually they tested 1,500 patients with type 2 diabetes and macroalbuminuria with moderate chronic kidney disease. The RCT was either losartan versus placebo, plus the conventional antihypertensive therapy. They followed them for 3.4 years, and they found that there was low incidence of end-stage renal disease and doubling serum creatinine with losartan. The mean blood pressure throughout the study was lower among those assigned with losartan as well. AIRMA trial in type 2 diabetes. was published in New England Journal of Medicine in 2001. They included type 2 diabetic patients and hypertensive patients, along with microalbuminuria. So it was double-blinded, randomized trial, irbesartan versus placebo. And actually, the irbesartan group was 150 and was 300. Okay. What was the result? Well, this is the primary outcomes, the time to the onset of diabetic nephropathy. And they found actually that there were less patients in irbesartan groups reached the primary outcomes. The primary outcomes is greater, having albumin to creatinine ratio of greater than 200 milligram and at least microgram, and at least 30% higher than the baseline. The average blood pressure during the course of the study was almost, similar in all groups. And despite of that, irbesartan actually of 300 milligram, independent of its blood pressure lowering effect, was renoprotective. Okay, let's now move to the new group of treatment that we're using now in type 2 diabetes mellitus. We're not using it in type 1, the SGLT2. And the reason why we're not using it in type 1 is because of the significant incidence of euglycemic diabetic ketoacidosis. So that's why we're not using it in type 1 diabetes mellitus. So in type 2 SGLT2 inhibitors, there are actually several studies in the past 6 years, talking about the SGLT2 effect on the kidney as well as the cardiovascular effect. So let's start with this one, the credence. They were actually testing at that time the canagliflozin in type 2 diabetes mellitus. They included good number of patients, like 4,000 patients with type 2 diabetes and albumin to creatinine ratio of more than 300 milligram. The mean GFR was 57, the mean albumin to creatinine ratio was 900, and they made sure that those patients are on the maximum tolerated dose of ACE or ARBs for 4 weeks prior to the randomization. And after 4 weeks, they randomized them to canagliflozin versus placebo. And they found actually that at 2.6 years, everything actually is positive and towards canagliflozin, if you see in all these diagrams. It reduced the incidence of end-stage renal disease, doubling serum creatinine, hospitalization for heart failure, cardiovascular death, and all cardiovascular mortality. And the beneficial effect of canagliflozin on slowing kidney function decline appeared to be similar among those with baseline of less than 30 millimeter mercury. Having said that, we're not so far using the SGLT2 inhibitors for patients with less than 25 millimeter per minute, with eGFR of less than 25 millimeter per minute. So far, we don't have good evidence to allow us to use it among these patients. So that was a positive study. Do we have any other positive studies? Yes, the one that was published actually recently, last year or the year before, because we just entered the new year of 2022. So in dapagliflozin, DAPA-CKD study, they actually looked at the patients with diabetes type 2 and chronic kidney disease in general. Let's say 2/3 of them were diabetic, okay, with GFR between 25 and more than 75, and urine creatinine ratio of more than 200. They excluded, the type 1 and other major causes of kidney disease. And they randomized them into dapagliflozin and placebo, and they followed them for like 4 years, almost 4 years. And the result was actually, again, significant. Look at the diagrams. It's significant in terms of cardiovascular death or hospitalization. It's significant for death from any cause, significant for renal composite outcomes. I have to say that almost all the patients on ACE or ARBs And in 2.5 years, dapagliflozin reduced all the causes as well as the incidence of end-stage renal disease. And also it reduced the risk of a 50% or greater decline in the GFR. And that was not specific for diabetic patients. 1/3 of the population were non-diabetic, and they saw actually similar beneficial effect on those group of patients. Yeah, we're waiting for the IMPACT kidney study. It's expected to be published in this year as well. Based actually on these two studies, yeah. How about the let's say the side effects between the different types of SGLT2 inhibitors? Well, you know, maybe higher risk of amputation in CANVAS study. However, the FDA removed the warning, the black warning, related to CANVAS study or related to the canagliflozin, because the evidence beyond that was not really solid. So it's not anymore black box warning about the canagliflozin in terms of limb amputation. You know, bone fractures, yeah, some of them were associated with bone fractures. I may not actually use it in patients who is known to have, you know, recurrent kind of bone fractures. Patients who have like bad UTI infection, again, it's not preferred to use the SGLT2 inhibitors. Many actually of the studies showed that there is a risk of genitourinary mycotic infections in those patients receiving the SGLT2 inhibitors. The reason is we're actually excreting the glucose in the urine in high amount, and that is why probably those patients at higher risk of having urinary tract infection. Because of the previous, you know, very positive studies, nowadays we put the patients with type 2 diabetes mellitus who has GFR of more than 25 and albuminuria, micro or macroalbuminuria on SGLT2 inhibitors in addition to the ACE and ARBs. How about the use of GLP-1 in type 1 diabetes mellitus? Well, we know that there is a good cardiovascular benefits from the GLP-1 in type 2 diabetes mellitus. The same study actually was followed, and they found a good as well renal protective evidence. This RCT was, you know, containing including large patients, almost about 9,000 with type 2 diabetes mellitus and high cardiovascular risk. They followed them for around 4 years, and the secondary outcomes, and this is what this study was about, a composite of persistent macroalbuminuria, persistent doubling serum creatinine, end-stage renal disease, or death due to renal diseases. And they found that liraglutide actually reduced the incidence of the composite renal endpoints, mainly persistent macroalbuminuria. All right. The last, but not the least, in the last decade about the diabetes. Many studies actually published for the care of cardiovascular and renal protection in patients with type 2 diabetes and type 1 diabetes in the past 10 years, which is good. Finerenone, the non-steroidal mineralocorticoid receptors antagonist. Probably you know about this study. It's another famous study that was published recently in 2020, where they actually looked at 13,000 patients, right? And 5,000 were randomized, were candidate or candidate for the enrolling criteria, and they ran with a follow-up of around 2.5 years. This study, the primary endpoint was the kidney composite points, which is not usual, to be honest, for the previous studies. Usually the kidney outcomes are the secondary, and I get that. I know why because they want the cardiovascular, which is the more important than the kidney composite endpoints. I know that there is no point to live if you to look at the kidney function if the patient has already died from cardiovascular event. So, but this study, what gave that a strength is actually that the primary outcomes was the kidney composite endpoints. So what did they find? Actually, they first of all, they included the patients with albuminuria, micro or macroalbuminuria, with GFR 25 to 70. And they found the following: patients who got finerenone, actually, they at 2.6 years time, the finerenone decreased the incidence of declining in the GFR significantly. So the incidence of a 40% or larger decline in the GFR in 2.6 years time was much better with finerenone group. The secondary composite outcomes was significant as well. That was concerning the cardiovascular events. Okay. The same study, actually, they just published a follow-up results. They found also that the finerenone has actually a good effect on patients with type 2 diabetes mellitus in terms of less hospitalization due to heart failure. So let me summarize the things again. So what are the things, the interventions that we do in type 2 diabetes mellitus with kidney disease? We started with the glycemic control, and we show that we have a good evidence saying that, or dictating that, having good and intense glycemic control would help in terms of decreasing the albuminuria, and which is the most important thing, decreasing or halting or protecting the kidney from rapid deterioration. The blood pressure, we saw studies that showed that intensive control of blood pressure would help in actually getting the proteinuria less, and also it was helpful in decreasing the cardiovascular events. In non-diabetic patients, we know the SPRINT trial effect on cardiovascular and stroke, right? I would say there is no reasons to think otherwise in diabetic patients. Controlling the blood pressure is of great importance. The use of ACE or the use of ACE or ARBs, we do not combine them anymore nowadays. So the use of ACE or ARBs in type 1 and type 2 diabetes mellitus found to show significant renal protection and decreasing albuminuria, especially if the patient has macroalbuminuria. The use of SGLT2 inhibitors is very effective in type 2 diabetes mellitus in patients with eGFR more than 25, and it was found actually to be renal protective as well as cardiovascular protective. GLP-1, this is we're not really paying attention to. GLP-1 has a good effect on decreasing the weight, as we all know, right? So, but that was not the only effect. Actually, it has renal protection, evidence for renal protection, as well as protection from cardiovascular events. And the last medication that was actually positive in the era of management of diabetic nephropathy, the finerenone, which showed significant actually decline or decreasing the incidence of hospitalization and decreasing the incidence of renal decline by more than 40% in patients with type 2 diabetes mellitus. Thank you so much for listening, and I hope you found it useful. Happy to receive any questions.
Thank you, Dr. Muhammad. It was really a very nice presentation. And we have only one question. If we have a patient with diabetes mellitus and he is well controlled with metformin, his blood sugar is well controlled, and he's asking, is there an indication to add SGLT2 inhibitors, or is it enough for him right now because he's controlled with metformin?
Well, it is not the only indication to give SGLT2 inhibitors in those patients is the diabetic control. We still give the SGLT2 inhibitors in those patients, even though their glycemic control is okay, as long as they have GFR of more than 25% or 25 ml per minute and albuminuria of more than 30.
Okay, thank you. And thanks for joining us. And you will be waiting with us for the next 30 minutes to enjoy the presentation from Dr. Khalid again about resistant hypertension. Thank you, Dr. Khalid. Please start sharing your screen.
Assalamu alaikum.
Wa alaikum assalam wa rahmatullah.
I'm back again, and it's my pleasure to be talking after Dr. Al-Khwaiter. It was a nice presentation. So if you may allow me, I will start giving my presentation. So I have, again, no conflict of interest. And this is the outlines. So I'm going to talk about definition, prevalence, diagnosis, and management. I'll try to make it light, okay, because it's Thursday evening time. So the definition, what is the resistant hypertension? So it's defined, there's different definitions, but I think this is the most common used one, is that the blood pressure that remain above goal in spite of concurrent use of 3 antihypertensive agents of different classes. But we have to keep in mind 2 points. If tolerated, one of the 3 agents has to be diuretic, and all agents should be prescribed at maximum recommended dose or maximally tolerated antihypertensive doses. And why these 2 factors are important? Because when we come to the risk factors or the causes of resistant hypertension, it will be clear why definition it came this way. The other definition also is the patient who has a blood pressure which is controlled with 4 or more medication should be also considered to have resistant hypertension. So either that you have uncontrolled blood pressure with 3 agents, including diuretic at maximum doses, or if the blood pressure is controlled, but it requires 4 or more medication to control it. Another definition is that we have to keep it in mind. As you know, we have the apparent resistant hypertension, but we have to confirm it. Okay, we have to have a true resistant hypertension, because we have this terminology, which is pseudo hypertension, which is the causes of that. For example, when the patient come to the clinic, they will have high blood pressure. You assume that they are on 3 medication and the blood pressure is still high. That means it's true resistant hypertension. But sometimes you have to make sure that the measurement is accurate. And we will talk about the appropriate way of measuring the blood pressure. So if it is self-measured by the patient himself, maybe the device is not accurate. The way it's done in the clinic is not appropriate, or other reasons that I will mention a few of them. Poor adherence to antihypertensive therapy. And we have to emphasize about this point, we have to make sure that the patient is really taking the drugs. And some patients, they think that the antihypertensive medication are PRN, or they can choose which one to take it today and leave the other. So adherence is important, or the suboptimal antihypertensive therapy. And this is what we mentioned, that has to be maximal dose or maximal tolerated dose. Poor adherence to lifestyle and dietary approach. And this is really important because some patients, they have no restriction to salt and others. So they come eating a lot of salt, and from different studies, we know that the effect of, for example, ACE or ARB is mitigated by 25% because of the use of salt. The other differential is, or other cause is white coat hypertension. And that's why we have to confirm this is a true resistant hypertension. How about the uncontrolled hypertension? We should not mix the uncontrolled hypertension with resistant hypertension. They are not similar to each other, okay? So the uncontrolled, yes, the patient maybe have high blood pressure, but maybe is in 2 drugs only, or he's using half doses, for example. So yes, this is uncontrolled blood pressure, but it's not resistant to the treatment. The last definition is about refractory hypertension. And what's the refractory hypertension is when patient is having high blood pressure, although on 5 or more medication, still not yet controlled, and the patient follow the whole algorithm, and yet there is no proper control, then we will label the patient as refractory hypertension, and we will have he or she need to go to a specialized clinic. How about the prevalence of the resistant hypertension? Is it an uncommon thing? Well, from different studies, like the one in the United States by the NHS, they found that resistant hypertension is prevalent about 16% of patients. So it is not an uncommon thing. And another study from Spain, they found that the prevalence is 12%, and they included 68,000 patients in that study. So it is not uncommon to find a resistant hypertension, and maybe if left neglected, it will have its own complication. Let me tackle another two terminologies that we have to keep in our mind about the blood pressure control. So this is on the left here on the axis is the ambulatory blood pressure, and this is the manual office blood pressure measurement. And both of them, for example, if you have blood pressure less than 140, then this is normotensive. But if your blood pressure is high at home and it is normal in the office, this is masked hypertension. If your blood pressure is high in the office, but it is controlled at home, this is a white coat hypertension. If it is elevated in both reading in the office and at home by ambulatory blood pressure reading, then this is a true hypertension. And are these two things are important? Yes, they carry a risk of cardiovascular mortality. So if we look here at the events of cardiovascular mortality for 100,000 patient years, this is the risk for normal for people who do not have it. For people who have white coat, it's a little bit elevated. For people who have uncontrolled blood pressure, the risk of cardiovascular is elevated, 25 in comparison to the normal. And the masked hypertension is the highest one, that it will lead to our conclusion that we have to check by using ambulatory blood pressure reading or home reading rather than just the regular clinic visit reading. What are the risk factors for resistant hypertension? As we mentioned before, suboptimal therapy. So we have to make sure that we are reaching the maximum therapy, and it's not a common thing. We see it. We have referral for uncontrolled blood pressure, and the patient is it's not in full control or full dose. I mean, doses, for example, they have half dose or even less than half dose, and they choose another agent and a third agent without choosing the proper dose or the proper regimen. Lifestyle and diet, and this is important, as I mentioned before. And actually, our colleagues in cardiology, what they do, they actually do a 24-hour urine collection to check the sodium amount to make sure that they are really having a restriction to diet, which is something we don't do usually in nephrology. Medication, it could be a risk factor, like, for example, non-steroidal, oral contraceptive pills, some abuse medication, and etc. So we have to review the patient medication carefully. The extracellular volume expansion, and this we can see it in patients, for example, with impaired renal function. They will have retention of salt and water. This will lead to high blood pressure reading, and we have to screen for secondary causes of hypertension. If we look at this diagram for the diagnosis and management of resistant hypertension here, so we have to confirm it with office systolic blood pressure or diastolic over 130/80, and the patient is already on the 3 drugs, including diuretic, or the out of or office less than 130/80, but patient require more than 4 antihypertensive. Then we'll go to the next step. We have to exclude the pseudo resistance and all the causes that we mentioned. So we ensure accurate office blood pressure measurement. We have to assess the non-adherence with the prescribed regimen. We have to have obtain home and work or ambulatory blood pressure reading to exclude the white coat effect. And we have also to identify the reversible causes like lifestyle factors obesity and other sedentary life. We have to discontinue or minimize interfering substances, and we have to screen for secondary hypertension causes. Before I go to the treatment, I'll just share with you the out of the office assessment and when to mention. This is from the Canadian guidelines. So for example, if you have hypertension visit, this is the first time you'll take history, physical examination, and do some diagnostic test. If the blood pressure is very high, more than 180 over 110, this is hypertension. You don't have to wait for another visit to confirm it. If the automated office blood pressure reading more than 135 or 85, or the office blood pressure measurement more than 140 over 90, so if it is not, then it's not hypertension. If it is yes, we have to confirm it by the out of office assessment. So what are the out of the office measurement or the benefits? So the out of the office measurement, it will identify the white coat hypertension and mask hypertension, which I mentioned before. It's important. And the automated blood pressure monitor, it is better than even the office blood pressure monitoring because it has a better predictive ability and it's highly recommended to be used. The home blood pressure monitoring. So the home, how is it different than the automated? So the automated, you will fix the device for the patient and will monitor for 24 hours. The home-based or home blood pressure monitoring, you will ask the patient to take the measurement with a device and bring it to you. And also this is shown to have better predictive ability than the office, and it's recommended if the ambulatory is not tolerated or it's not available in the hospital. So the best one is that you will use the automated to confirm the blood pressure. If not available, you will use then the home-based or the home blood pressure monitor device. If both options are not available, it can't be done, then third option, we will use the automated office blood pressure measurement. And we have different devices for these. And what they will do actually, when the patient come to the clinic, they will take different reading and they will take the average. And for example, usually they take 5 to 6 reading on the same setting, and then they will take the average for the patient or the average blood pressure. So is it important or does it have any evidence? Yes, it's almost closely approximate to the automated than the routine office, and it also mitigates the white coat effect. So it is superior to the usual office reading, and it's more predictive of end organ damage like left ventricular MI, proteinuria, and other risk factor, which is similar to the automated. So if we take it in a sequence, if we have suspected resistant blood pressure, we would go with ambulatory blood pressure reading or home blood pressure reading if it's not available. The third one will be the automated office blood pressure measurement. And the out of office blood are more highly correlated with the blood pressure related risk. If you can here see it with the LVH, with the albuminuria regarding the systolic and diastolic, you can see the best one here is ambulatory blood pressure or automated ambulatory blood pressure measuring home, then the office reading. How about the different or the cutoffs for the blood pressure measurement? We have to make sure that we understand the cutoffs for the diagnosis of hypertension depends on the type of blood pressure measurement. For example, if you are checking the daytime, it's different than the nighttime. And the average ambulatory blood pressure, the normal blood pressure is 115 rather than the 120 that we use it as cutoff. And also for the definition of hypertension, stage 1 and stage 2, they are different and we have to keep it in mind. What are the causes of secondary hypertension? As all you know about it, we have to keep them in mind, like renal parenchymal disease, renal vascular disease, primary hyperaldosteronism, obstructive sleep apnea, and drug or alcohol induced hypertension. The uncommon causes like pheochromocytoma, Cushing syndrome, hypothyroidism or hyperthyroidism, aortic coarctation, and others. If you look at the primary aldosteronism, it's maybe underdiagnosed in the setting of high blood pressure. And they found in one study like 20 to 30% of patients, they have primary hyperaldosteronism and it's not discovered or missed. And one of the clinical features is looking for patient who's not fitting the criteria for essential hypertension. They might have hypokalemia, but we have to keep in mind that 50% of patients who have a primary hyperaldosteronism, they have normal potassium level. But in the setting of resistant hypertension, always it is one of the important factors. The other thing is renal artery stenosis. Of course, again, if we have hypokalemia or a young patient, female patient, we have to suspect it, for example, in case of fibro muscular dystrophy and others. Obstructive COPD, it's not uncommon. It's missed by many of us. We have to keep it in mind, especially if the patient is having typical features. So we have to refer them for proper treatment. And in some study, the effect of controlling the obstructive COPD might improve the blood pressure control by 10 to 15 millimeters mercury. Now, this is the screening for secondary hypertension. When we suspect it, if we have resistant hypertension is one of the causes. In addition to that, if we have abrupt onset hypertension or onset of hypertension in patient less than 30, if we have exacerbation of previously controlled blood pressure, if we have accelerated malignant hypertension, if you have end organ damage out of proportion of the hypertension, and if we have unprovoked or excessive hypokalemia. If any of these features is met, then we have to screen for secondary hypertension. And if it is positive, we have to refer the patient to the proper service. If none of them is met, then we don't have to screen for secondary causes of hypertension. Now we talked about the confirming the diagnosis, how to approach it. Then we are going now to the medical or the management of those patients. So we start by the non-pharmacological recommendation. So we have different recommendations that you can see here, like weight loss, proper diet, sodium restriction, potassium supplement. You can see here the level of evidence is high, so these are important. And the coming slide, I will mention to you the effect, how much each one of them, they contribute to the reduction of blood pressure. Also, doing exercise is important to control or the non-pharmacological treatment. So here, if we look here about the weight loss, it can, if you lose weight, for example, and it can help and you achieve your target of weight reduction, you can reduce the blood pressure by 5 millimeter mercury. If you use the DASH dietary pattern, which is consuming food rich in fruits and vegetables, whole grains and others, you can reduce it by 11. If you reduce the dietary intake to less than of sodium to less than 1500 milligram per day, you can reduce it by 5 to 6. If you take some potassium, also it will help. And actually, the effect of potassium, it has vasodilatory effect, so it might help to relieve the blood pressure. The exercises, it depends on what type of exercise. Also, it has some effect, for example, aerobic or isometric resistant and other. How about the pharmacological treatment? Yes, as we mentioned here, if we remember that once we give the maximum dose and including diuretic, so what type of diuretic we have to give? So we have the thiazide-like, which are preferred, or the thiazide group in general, or the thiazide-like. There is some evidence about if we use longer acting diuretics should be preferred. So we have the longer acting like thiazide-like chlorothalidone or indapamide. Chlorothalidone maybe it's not available here locally, but we have the indapamide, and we have the short acting that everybody is familiar with is the hydrochlorothiazide. So in one meta-analysis, when they compared which one is better, so both types of or both of these diuretics, they reduce the cardiovascular event and cerebrovascular event and heart failure. But if we see at the thiazide-like, they also reduce the coronary event and all-cause mortality. You can see it here, the difference here between them. It's evident in the thiazide-like. Here, it's crossing the unity, so it's not significant. Also, the thiazide-like, they did better. This is the overall mortality. How are the effect on blood pressure itself? So chlorothalidone, it seems to be more effective than hydrochlorothiazide in blood pressure reduction. And if you can see here, this is in the gray, the chlorothalidone. It has better blood pressure control more than the hydrochlorothiazide. So to conclude, they are better in reduction, and overall mortality is better with the longer acting. So this is about the one approach is adding appropriate diuretics. But we have to keep in mind when we mention diuretics that they have the better effect if the GFR is more than 30 ml per minute. If the GFR is less than 30, their effect is less, and it's recommended to stop them. So at this point, if the patient has a severe renal impairment, we recommend to use loop diuretics like Lasix or others. Although in some studies recommend that the longer acting diuretics or loop diuretics like torsemide has better effect than the short acting like bumetanide or furosemide. How about the other approach? So the single pill combination in the new guidelines from the Canadian guidelines, they added to the first guideline that single pill combination. And does it help? We can see here what is the advantage of this combination. So it is associated with better adherence versus the free combination, and the regimen of single pill combination lead to better blood pressure control. And as you know, this is an important factor, the adherence which lead to pseudo hypertension. And the initial combination therapy is associated with decreased risk of cardiovascular event than the monotherapy. And this evidence is coming actually when we combine the ASRR with calcium channel blocker or diuretic. We have two trials, the HOPE-3 trial, which demonstrated the superiority of single pill combination versus the placebo. And in this, they combined ARB with diuretics, and the ACCOMPLISH trial where the ACE plus calcium channel blocker combination, it was better than the active control. So we have now two approaches using the appropriate diuretic, the hydrochlorothiazide group. If not it's not possible, we can go for loop diuretic. Then the second approach is the single pill combination. The third drug, which is also recommended for resistant high blood pressure reading, is the spironolactone or the potassium sparing agent. We have different trials, but I think the famous trial which brought the best evidence was the pathway trial, when they used the spironolactone versus placebo, bisoprolol or deoxycytosine. It's a randomized double-blind crossover trial. And this is just the concept of that trial. Initially, they screened more than 400 patients. And at the end, the patient who completed the treatment, they were 230 patients. And when they looked at the result, if we compare, you can see here in the diagram, this is the home blood pressure reading, and this is the different category of our patient. So this is the baseline, the blood pressure baseline, and this is the patient who received the placebo. And here is the patient who received the spironolactone at dose 25 to 50 milligram. You can see here there's significant reduction between the placebo and spironolactone with a statistically significant p-value. And if you compare it, the spironolactone versus the other intervention, deoxycytosine, the alpha blocker or the beta blocker, you can see here the spironolactone has better efficacy in comparison to the two medication. Here also we can see here the effect on the renin, and it changes in the blood and systolic blood pressure with the use of spironolactone here in comparison to the other intervention drugs. Here also they just measured in the same trial the effect on potassium, if there is more risk of hyperkalemia or hyponatremia or others. So to conclude from this, actually the incidence of hyperkalemia in those patients with resistant hypertension was only 2% of patients. In another trial, actually the evidence came again to be positive for the spironolactone when it was combined with the new oral or potassium binding agent like betorimir or others. So we have a strong evidence that the potassium sparing agent like spironolactone or even the others like ibuprofen or amyloid, they have a good effect to control or help to control the resistant hypertension. In some study, the reduction was up to 25 millimeter mercury, which is really significant for those patients who have difficult to control blood pressure. How about the other therapies? We can use vasodilators like minoxidil or hydralazine, but we have to keep in mind for minoxidil, actually it's a big gun. It's a good agent to be kept as last result, but we have to keep in mind this can cause fluid retention, and we have to use it in patients who are already on diuretic. Also, it can cause hirsutism. Hydralazine, it's another drug. I think it's commonly used. Again, it can cause a fluid retention, and now the new warning about it, that the new cases of uncassated vasculitis induced by hydralazine, so there's a concern to use it, and we might resort to better options. The alpha blockers like toxacin or prazosin, they are good agent to be used. The intervention like renal denervation, we have the famous Simplicity Hypertension 3 trials, and actually, yes, it showed some reduction in blood pressure control, but if we compare it to the placebo or standard of care, there was no significant. And also the same thing with renal hypertension trial. We don't have a strong evidence for renal denervation to control the resistant hypertension in our patient. The last intervention is stimulation of carotid sinus baroreceptor, or what they abbreviate as PAT. Again, we don't have strong evidence, so it's not superior or effective than the standard therapy. By here, I would like to conclude. Thank you for listening.
Thank you, Dr. Khalid, for this nice presentation. We have one question. Do beta blocker like Concor or Niblet can cause progression of diabetes? Because one of the side effects of beta blocker, dyslipidemia and impaired glucose tolerance. And can it worsen diabetic control or make pre-diabetic progress to diabetic? Thanks.
Well, yes, they might have, and in some studies, it shows, yes, they have potential for that. Honestly, I can't recall the evidence, but I don't think this is a significant effect. Otherwise, will be put in the guidelines as contraindication or should be avoided. Exactly. If it was. And we have to remember that those agents are excellent agents, and we use them when we have a compelling factor. For example, we have cardiovascular disease, we have MI or something. Yes, beta blockers are no longer a first line agent for management of blood pressure control, because we know that their effect on blood pressure is controlled. Maybe they are added in certain population if they have resistant hypertension, or if we have compelling risk factor like MI or ischemic heart disease.
Okay. And what about your experience with renal denervation in patients who were taking more than 3 drugs? Do you think it is a good option?
Well, based on the studies, it has no effect. Personally, I haven't tried before, honestly, and always we go with the medication. Maybe I will use minoxidil rather than using renal denervation. I don't have strong evidence to support it. Maybe if I fail minoxidil also and I have someone who has very high blood pressure, I might resort to it. But honestly speaking, I did not use it. I'm not sure if you have done or Dr. Muhammad have choose it.
I have two cases. They were on dialysis and receiving, I think, 5 medications for control of blood pressure. And this was, I think, 4 years ago. And our interventional radiology performed the renal denervation, and actually it was there was a success. Okay, they were kept on 1 medicine or maximum 2 medicine. And I searched behind the evidence behind these 2 cases. I couldn't find any evidence, especially they are renal failure patient and on dialysis. Then we stopped this intervention because we couldn't find a scientific background behind this.
Okay, maybe I hope we'll find like a trial which will show maybe a specific indication for the, maybe there's a subgroup of patients who will benefit from that rather than to generalize it in all resistant hypertension. Yes.
Okay, thank you, Dr. Khalid, for joining us today. And now we will be with Dr. Muhammad Al-Khwaiter. Dr. Muhammad, you are here with us?
Yes, I am.
Okay, sir. Now we will enjoy with you the second presentation about membranous nephropathy. Yes, exactly.
Yeah.
Okay, thank you.
السلام عليكم. مساء الخير مرة ثانية. It is a pleasure to be presenting after Dr. Khalid Al-Matham, a friend of mine and an excellent nephrologist. I'm going to talk, in this 20-25 minutes about the membranous nephropathy. The outlines of my talk is going to be touching base on the incidence of membranous worldwide and among the Saudi society. Presentation and diagnosis very briefly. The role of anti-PLA2R very briefly. I'm going to touch base on the risk stratification as well. And then I'm going to talk about the treatment, maybe with a bit of more details in the past 5 years. And finally, we'll touch base on the anticoagulation. Okay, so first of all, membranous nephropathy is the most common cause of nephrotic syndrome in adult and one of the leading cause of end-stage renal disease. 30%, 20 to 30% actually of nephrotic syndrome in adult is caused by membranous nephropathy. Its incidence rate worldwide is about 1.2 per 100,000 year. As we all know, it is common. It actually represents 17% of the total glomerulonephritis cases as the third most common type of glomerulonephritis في المملكة. It is the second most common cause of glomerulonephritis in the United States, represent about 12.7% of all the cases. Okay. As we all know, it is usually primary in 75 to 80% of the cases. Patients usually present typically with nephrotic syndrome, full-blown nephrotic syndrome in like 75% of the cases. How would we diagnose it? In addition to the clinical presentation, we may actually keep into consideration the phospholipase A2 receptors antibodies. The phospholipase A2 receptors, or the PLA2R, actually it's a membrane that works as a receptor at the glomerular podocyte surface, and it's highly expressed in the podocytes. It is the target antigen for the antibodies involved in the pathogenesis of membranous nephropathy, and it was identified in a very famous study published in New England Journal of Medicine in 2009 by Dr. Beck. 80% of the patients with primary membranous nephropathy have positive anti-PLA2R antibodies. Not only that, the presence of anti-PLA2R antibodies in the serum or even in the renal biopsy is the most predictive features for the diagnosis of membranous nephropathy. Why I am saying that? Because it is sensitive. We're talking here about 80% of the cases of membranous nephropathy have positive anti-PLA2R. And it is specific. It is actually quite specific when you actually keep into account membranous versus non-membranous. It can even reach up to almost 100% specificity. However, if you want to use it to differentiate between the primary and secondary membranous, the specificity decrease to maybe 70%. We have actually variable, studies that reported different kind of rate. In some studies, the specificity reached up to 95%, and in other studies in 60s. Here we have a study, for example, that tested more than 400 patients. 252 of them were known to have primary membranous, and 32 have secondary membranous. And they found that actually the specificity of primary versus secondary forms of membranous for PLA and for anti-PLA2R reached 70%, while it's almost 100% for membranous against non-membranous. So we're talking here about a sensitive and specific tool of diagnostic testing that would help in reaching the appropriate diagnosis. And as a result, I'll ask you a question. Do I have to do kidney biopsy for those patients if the PLA2R antibodies is positive? Well, the answer is no. The answer is no. And we'll come to this slide. Okay, if you're saying that we still could have positive anti-PLA2R in secondary membranous, then we still should screen all the patients with membranous nephropathy and positive anti-PLA2R antibodies for the secondary causes. All right. So, and that includes several things actually: doing chest X-ray or CT scan if the patient is smoker or has been known to have smoking for long years. In addition to screening for malignancies that match the age, appropriate for age. We'll do ultrasound kidneys. Of course, we'll get detailed history about NSAIDs. In the old days, they were using gold and penicillamine. We're not using them really anymore. Nowadays, very limited use. We have to screen them for hepatitis B, C, and HIV. And of course, we have to take full history, looking for any evidence of lupus or thyroid diseases, etc. Okay. So will we do kidney biopsy for patients who present with full-blown nephrotic syndrome and positive anti-PLA2R? Since the sensitivity and specificity is significantly actually high, I wouldn't. And that's what KDIGO guidelines actually is saying. If you have normal kidney function and you're not intended to give any immunosuppressive therapy, then for sure there is no need for kidney biopsy. If you are going to give immunosuppressive therapy, maybe yes, maybe no, but we don't need to do it, okay? However, if the clinical presentation is not that typical, I would say, or if the patient has more RBC cast in the urine, or it behaves, in a different way, let's say, or the patient deteriorate his kidney function over a short period of time, then yes, proceed and do kidney biopsy. How about, you expect membranous, but the PLA2R came out negative, then you're going to do kidney biopsy anyway, of course. Okay. Is there any other diagnostic tool? Well, in 2004, we were able to identify a new protein called thrombospondin type 1 domain containing 7A, all right? Having said that, the antibody against this protein can be only positive in 1 to 3% only of primary membranous nephropathy, okay? And in 10% actually of patients with membranous who were seronegative for anti-PLA2R, okay? It is limited. I mean, its use is limited. It's not yet FDA approved, okay? but it is an area of research right now. Its importance may be evident when the PLA2R is negative and this test is positive. Having said that, as you see, the sensitivity, it is low, very low actually. So just to let you know about it, but we're not using it in the clinical practice as we speak right now. Okay. How about the natural history of membranous nephropathy? Well, we know 1/3 of them, they will have spontaneous remission, and this is usually happens in the first 2 years presentation, but can occur at any time over the course of their illness. And 1/3, they will persist and have proteinuria, but with long-term preservation of kidney function. The third, they will actually progress to kidney failure. And this is the rule of third, we call it, in membranous nephropathy. How would you stratify the risk? Well, we know that the male gender, the diagnosis at older age, high creatinine at presentation, significant chronic changes on the kidney biopsy, all are associated with unfavorable prognosis. This risk stratification was based actually on Toronto Registry and a study that published in 1992. They looked at 184 patients and they evaluated them for the risk of progression to CKD, defined by creatinine clearance of less than 60 over a period of 5.8 years. And they came up with a model to stratify the risk. So the risk is going to be low if the patient has proteinuria of less than 4 grams, okay, and normal creatinine clearance. It's going to be moderate or medium, let's say, if the proteinuria is persistent for more than 6 months and it is between 4 and 8 in the presence of normal or near normal creatinine clearance. High when the proteinuria is persistently high for more than 3 months, or it is associated with worsening kidney function. The recent KDIGO guidelines have similar, actually, risk stratification. However, they have like very high risk group where when you have like life-threatening complications of nephrotic syndrome, like مثلا very bad infection or PE, pulmonary embolism, okay, or significant and rapid deterioration of kidney function over a relatively short period of time. Okay, how would we treat those patients? Well, that depends on the risk. If they are low risk, meaning proteinuria of less than 4 grams with normal creatinine, then we'll just treat them conservatively because they often develop spontaneous remission. The prognosis usually is excellent, okay? And that is why the recommendation from KDIGO guidelines is not to start them on any immunosuppressive therapy if the proteinuria is less than 3.5 gram, along with serum albumin of more than 30 and GFR of more than 60. How about moderate risk? Well, we treat them conservatively for the first 6 months, right? Because significant number will remit spontaneously, either to complete or partial remission after 6 months time of conservative therapy. However, if they are persisting to have, or if the proteinuria persists beyond the 6 months without any evidence of the proteinuria trending down, then you may consider actually the treatment, the immunosuppressive treatment, okay? Which kind of treatment you're gonna use? Well, we'll take them by evidence. So we have the Ponticelli study. It was published, like 30 years ago, maybe, yeah, 1995. They tested actually steroid and chlorambucil versus symptomatic treatment. This is the common kind of, or the most famous kind of a steroid regimen that is used for membranous nephropathy, the methylprednisolone pulse therapy in day 1, 2, 3 in the first, third, and fifth months, followed by 0.5 milligram per kg in the first, third, and fifth months. In between, they gave chlorambucil orally in the month of 2, 4, and 6. This is what they did. They had 81 patients and they followed them for 10 years. And they have actually moderate risk because proteinuria was 6 grams in the mean. And the patients who were treated with immunosuppressive therapy had better complete and partial remission versus supportive therapy, and also have a higher rate of surviving without end-stage renal disease. Okay. Okay. This study actually, they looked into the mortality in those patients. Okay, and that what gave it a strength. In any guidelines, they still mentioning the Ponticelli protocol because of the moderate, I would say, good quality of evidence we have with this study. Okay, any other treatment? Well, this Ponticelli study, they used chlorambucil. They did not use cyclophosphamide. After this study, there was another study by the Ponticelli group, and they tested chlorambucil versus cyclophosphamide, and they found actually comparable results. I mean, of course, for shorter period of time, they found comparable results with less side effects with cyclophosphamide, and that shifted the management from chlorambucil to cyclophosphamide, and they call it the modified Ponticelli protocol. Okay. In 2007, however, Jaha has published his study, which tested exactly cyclophosphamide this time, not chlorambucil, cyclophosphamide and steroid as per the Ponticelli protocol versus the supportive therapy with 10 years follow-up. Small number of patients, but again, they looked at the exact, outcomes, the partial and complete remission, as well as surviving without end-stage renal disease. Okay, and was actually positive for the use of steroid and cyclophosphamide. Okay, so we have acceptable and good evidence for the use of cyclophosphamide and steroid in the management of membranous nephropathy. How about CNIs, cyclosporine or tacrolimus? We have actually two small studies that included small number of patients. Okay, they tested the CNI versus supportive therapy, and they found that actually a significant higher rate of complete and partial remission with treatment. However, the relapse rate was higher when you withdraw the treatment or you discontinue the treatment. It reached up to 45 to 50%. 45% in the cyclosporine group and 50% in the TAC group, which is really quite significant. Okay, how about using rituximab in moderate risk? Well, GEM-Retox, published 5 years ago in 2017, 75 patients, French hospitals, moderate risk, proteinuria of 7 grams, persistent for more than 6 months, along with near normal creatinine. And they actually randomized them to rituximab versus continuing the supportive therapy. The rituximab was given in 2 doses, 8 days apart, or 7 days apart. And they found that there was no significant difference between them at 6 months. However, at 12 months, the rate of complete or partial remission was higher among patients treated with the rituximab. What does that tell you? It tells you that membranous nephropathy respond slowly to the treatment. Okay, that you may not see any significant difference in the first 6 months. All right, but we would expect to see a difference afterwards. Any other studies that published recently? We have actually the Mentor study, and the Mentor study, they considered it as a treatment for the high group, probably because the median proteinuria was 8.9 grams, okay? But when you look at the mean creatinine, it was 1.3, okay? So it was 130 patients, and it was open label randomized trial. They randomized the patients into rituximab, 2 infusions, 1 gram, 2 weeks apart. Okay, and they repeated it at 6 months in case of partial response. Okay, so if you have at least more than 25% improvement in the proteinuria, they will give a second course of rituximab versus oral cyclosporine. This is, I believe, the first randomized trials that tested rituximab versus cyclosporine head-to-head. And they followed them for 2 years. And here is the result. At 12 months, the rate of complete or partial remission was similar between the 2 groups. So CNI, they do well, actually, in short term. However, at 24 months, rituximab group had a higher rate of complete or partial remission than cyclosporine, significantly, okay? And only patient receiving rituximab, they achieved complete remission. There is none patients in the cyclosporine group did achieve complete remission. Complete remission is defined as having a proteinuria of less than, I believe in this study is less than 0.5 grams, if I'm not mistaken. Okay, not only that, among patients in remission who tested positive for anti-PLA2R antibodies, the decline in the autoantibodies to the anti-PLA2R was faster and greater magnitude and duration in rituximab group than in cyclosporine group. So if we believe that anti-PLA2R antibodies is the pathogenic antibodies beyond the development of membranous nephropathy, then rituximab decreased them and reduced them quite or significantly compared with cyclosporine, which probably indicates that we will have better control on the disease. Okay. Do you have any other randomized trial in the high-risk group other than Mentor study? Yes, we have the UK membranous trial, 100 patients, divided them into 3 arms. Okay, so it's a small number of it's small study, I would say, underpowered, I would say. So creatinine was 300, less than 300, and at least 20% decline in GFR during the preceding 2 years. So they picked a high-risk patients for progression, and they randomized them into 3 arms: supportive plus Ponticelli protocol, the old one with chlorambucil, versus supportive plus cyclosporine for 12 months versus supportive treatment. It was published in 2013, I believe, yeah. And look at that. They found actually that the rates of primary endpoints was significantly better with prednisone and chlorambucil group. However, I have to say that the dose of cyclosporine was not escalated appropriately. I believe they started with 5 milligram per kg, which is high initial dose for cyclosporine. Maybe that's why we do not have a favorable, outcomes in relation to cyclosporine. I say maybe. And most of the patients followed for less than a year. And in membranous nephropathy, you need to have at least 1 year, if it's not more than that. And 3 arms with 100 patients, so it is a small study. That were the limitation of the UK membranous trial. And that's why the level of evidence for this study is low. It's low. We can't say it's good. It's low evidence. It's low quality of evidence. Okay, so let me again rephrase it and say, what are the recent study with head-to-head comparison? Okay, do we have a studies cyclophosphamide versus head-to-head versus CNI? We have a meta-analysis that published in 2006-17. They looked into the cyclophosphamide studies and TAC studies. They included 4 RCTs and 2 prospective cohorts. They almost included 400 patients, and they found that the renal remission rate were not significantly different between the tacrolimus and cyclophosphamide group. However, tacrolimus was actually, they found more relapses with the CNI groups, with the tacrolimus group. Okay. The tacrolimus was inferior to cyclophosphamide after 1 year, as we expect. The cyclophosphamide group had significant higher risk of leukopenia, whereas the tacrolimus had significant higher rates of tremor. but no difference in the serious side effects. How about cyclosporin versus rituximab? We mentioned already the Mentor study that was positive for rituximab. Okay. How about cyclophosphamide and steroid, the modified Ponticelli protocol versus rituximab? So we have the Ponticelli versus the CNI. We have the CNI versus rituximab. Do we have Ponticelli, modified Ponticelli versus rituximab? Yes, it's a pilot study, the RI cycle. It's the first RCT to compare rituximab versus cyclic steroid and cyclophosphamide. It was published the last month of the last year, actually, and they included 74 patients, open label, moderate risk patients with mean creatinine of 1 milligram and mean proteinuria of 6 grams. And they found that there was no significant difference between the two groups, in serum of creatinine and anti-PLA2R at the time of randomization, okay? What was the result? They followed them for 12 months. At 12 months, there was like a trend for better Ponticelli protocol, favoring Ponticelli protocol. Having said that, the total complete and partial remission were similar. In 24 months, however, the rates of complete or partial remission were comparable between the two groups. What does that tell you? It may tell me that rituximab takes some time to kick in, okay? Cyclophosphamide probably and steroid works faster than rituximab because at 24 months, there was no difference between them, okay? And the adverse events, no much difference in terms of adverse events. It is a pilot study. The aim was to see if rituximab is associated with less harm or associated with better benefits, okay? So that was the aim of the study, and it did not show that rituximab is superior to the Ponticelli protocol in either way, okay? Okay, and last but not least, we'll talk about the study that compared actually, it's a different kind of the study, this Starman study. They gave the patient the Ponticelli protocol in one arm, cyclophosphamide and steroid, and they gave sequential therapy in the second arm. They gave TAC for 6 months, and at 6 months, they gave rituximab, okay? Then they tapered down the tacrolimus for the following 3 months. And, it was open label, 86 patients. The way it's moderate risk. The median creatinine was like normal, near normal, and proteinuria was 7.4 grams. And there was no difference between the two arms in terms of positivity of the anti-PLA2R. And here was the results. The result showed actually that, at 24 months, the complete or partial remission were higher actually with the Ponticelli modified Ponticelli protocol in comparison with the TAC rituximab group. Even the secondary endpoint, which was the complete remission, was higher in the Ponticelli protocol in comparison with TAC rituximab sequential therapy group. Relapses happened more actually with the sequential treatment. Okay, so based on that, the study concluded that giving cyclic phosphamide and steroid is better than tacrolimus followed by rituximab. Okay, now after talking about the important RCTs that was published recently, only over the past actually 5 years. Now let's see what is the guidelines is saying about that. So first of all, we will not all patients with membranous should receive supportive therapy, i.e. blood pressure control, getting the lipids under control, low salt diet, maximum tolerated dose of ACE or ARBs, okay? Immunosuppressive therapy should be restricted to the patients considered at risk of progressive kidney injury. So you shouldn't give low risk any kind of immunosuppressive therapy because they have low risk, okay? For patients with minimal change, so with membranous nephropathy and at least one risk factor for disease progression, we recommend using rituximab or cyclophosphamide and glucocorticoids for 6 months, or CNI-based therapy for more than 6 months. Okay, so basically, you can use either one. You can use the Ponticelli protocol, you can use rituximab, you may consider using even the CNI, I would say, okay? And that you have to individualize your patients, to be honest. And I tend to use more rituximab in membranous nephropathy. I don't find, the Ponticelli protocol very practical. I have to admit the patients like for 3 days to get the methylpred in the first, third, and fifth month, okay? And I have to give the cyclophosphamide orally. The cumulative dose of cyclophosphamide will probably high and exceeds 8 grams in the treatment course. I have to follow the patients later, for the possibility of, complications, or especially if the patient is young lady, etc. Okay. So how about CNI? Well, if rituximab did not do the job, then you may consider CNI. If the patient had, let's say, rituximab kind of reaction, then you can use CNI. Or, for patients who actually you can be easily able to manage and admit, I think you have evidence and good quality evidence to give the Ponticelli protocol, of course. By the way, Ponticelli protocol is used frequently and more often in Europe and East Asia, okay? While the North America and maybe in our also country, we tend to use the rituximab CNI over the Ponticelli protocol. How about anticoagulation? Patients with membranous nephropathy at risk of having thromboembolic events. We look at the serum albumin. If the serum albumin is quite low, then this patient has high risk of thromboembolic events. We have to assess now the bleeding risk. If the bleeding risk is high, we give aspirin. If the bleeding risk is not high, then consider either therapeutic warfarin or low molecular weight prophylactic heparin and aspirin, okay? While if the patient has proteinuria of more than 25 or more than 20, if you're using this technique, then you estimate the thromboembolic events and you give the management accordingly, either aspirin or no aspirin. But we don't tend to give, warfarin or low molecular weight heparin if the albumin is more than 25, to be honest. Okay. Yeah, I remember a patient who actually had a PE during his first, presentation due to membranous nephropathy. When he had another relapse of membranous nephropathy, I just put him on a therapeutic, actually low molecular weight heparin, and I continued until he got a complete remission, and then, I stopped it. So having a previous risk or having a previous thromboembolic events would warrant anticoagulation, full anticoagulation, if there is no contraindication until the albumin, gets better. Okay. In summary, membranous nephropathy is one of the commonest form of glomerulonephritis. It's usually a disease of an older people. It is 80%, but can happen at any age. It can happen in pediatric age and can happen in even patients with, who are younger than 40-year-old. The typical presentation is nephrotic syndrome. However, 20-25% of them may present with subnephrotic range proteinuria. It is primary. We don't call it idiopathic anymore because we were able to identify the antigen involved in the pathogenesis. So now we call it primary. Primary membranous is 80% of the cases, okay? 20% could be secondary to malignancy or hepatitis or thyroiditis. Okay, the PLA2R has a very good predictive value for the diagnosis of membranous nephropathy. The sensitivity reach up to 70 to 80%. Specificity for membranous versus non-membranous is almost it's almost 100%, I would say, almost 100%. However, there is subgroup of patients with secondary membranous who may be seropositive for anti-PLA2R. That is why we still do secondary screening for malignancy and infection for any patients with membranous nephropathy. Since the sensitivity and specificity of the anti-PLA2R is high, we don't need to do kidney biopsy anymore if the anti-PLA2R is positive. However, if the presentation is not typical, or there is a rapid deterioration, or a lot of RBC cast, in the urine, then we may consider actually doing kidney biopsy. Or of course, if the PLA2R is absent from the beginning. Treatment, we do not treat for the first 3 to 6 months. Why? Because the spontaneous remission is high. Spontaneous remission is high. We do not even treat patients with low risk, i.e. less than 4 grams, even if they persist for more than 6 months usually, okay? Because still they have a good chance to remit in the coming 2, 3, 4, 5 years. In the moderate risk, we wait for like 6 months with supportive therapy and reevaluate the things again and put the things on the scale, okay? If we think that this patient is on a significant risk of progression, okay, then we proceed and give the immunosuppressive therapy. If the patient is high risk, i.e. persistent proteinuria of more than 8 grams or worsening kidney function, or he is at very high risk group where those who develop like PE or bad infection because of losing immunoglobulin in the urine or rapid deterioration of kidney function, then we even do not wait. We start the treatment. For very high risk, we start the treatment and we don't wait for like 3 to 6 months, okay? But for high and medium risk, we wait. Which kind of modalities or treatment modalities that I can use? Well, you can use Ponticelli protocol, the modified one, the cyclic steroid and cyclophosphamide oral. You can use rituximab. We have now good evidence for rituximab, and we can use CNI. As of yet, we don't have data for rituximab and CNI over a long period of time, okay? We don't have a data for rituximab and CNI that test the survival without end-stage renal disease, okay? That's only reported with cyclic, actually steroid and chlorambucil, steroid and cyclophosphamide, and that would give the strength to these regimens. However, given that it's not so practical, that what limited the use, at least in our country. That's the whole summary, and thank you so much. I'll be more than happy to receive any questions.
Thank you, Dr. Muhammad. It was a very nice presentation. You answered all the questions about membranous nephropathy, starting from the diagnosis and definition till the most recent updates. We have one question. Actually, these are my questions. In one slide, there was assessment of bleeding risk, and there is what's called the GN tool. I am not familiar with this. Do you have any answer for this?
Yeah, there is actually a score that you do to assess the bleeding risk. And based on that, you will come up with the risk. Is it high or low or intermediate? To
use either warfarin or aspirin, according to the bleeding risk.
Well, yeah, exactly. Aspirin versus warfarin, or aspirin versus aspirin and low molecular weight heparin. Okay. Regarding rituximab, you mentioned that you are using rituximab with all cases of membranous nephropathy, so you have a good experience with it, right? What is the dose you're using? Is it 375
per meter square every week for 4 weeks, or you have another regimen?
Well, I know I'm using the 1 gram 2 weeks apart. Okay.
Okay.
Yeah, and
Okay.
in adult, the R-cyclo study, where they use the 375, they actually gave 2 doses already, 7 days apart. 7 days apart. But Mentor study has more patients, I would say, and they use the usual kind of regimen, which is 1 gram 2 weeks apart. So I still stick with that.
1 gram 2 weeks apart, and after this, you're following your patient with level of proteinuria, progression signs.
Yeah, at 6. Yes, exactly. Yeah, at 6 months' time, I'm gonna reevaluate the things again. Of course, I'm gonna continue the supportive therapy, the blood pressure control, the low salt diet, the maximum dose of ACE or ARBs, statin if required, and reevaluate the thing in 6 months' time. If there is a trend,
you're using the level of BLAR antibody.
Unfortunately, we send it out, but sometimes it takes time to come back.
Same here.
Yeah, so that is I hope we have it soon. I hope so. But for the time being, that's a very good point, Dr. Ahmed, لأنه anti-PLA2R, the reduction in the anti-PLA2R is, as you know, a predictive of response. And we see the reduction, the biochemical reduction before the clinical reduction or the clinical improvement. Okay, so that is why they at 6 months, some of the schools, they repeat the anti-PLA2R, and they stratify whether the patients will likely improve or not, whether they will give another dose of rituximab or not. But what we do, we evaluate the things at 6 months' time, 4 to 6 months' time. If there is a trend toward remission that reach 25%, as low as 25%, we will not change the management, and we will be more than happy just to follow the patients, because we know that the response rate is slow actually, and it takes time to remit. In some studies, the partial remission can take up to 23 months. Okay, so this is the nature of the disease. This is how the disease actually, react. So for those patients, we follow them in 6 months. If we see just slight evidence of improvement, we just continue, observing them along with the giving them the appropriate treatment. If there is, as I say, as low as 25% improvement, at that point, we can even give them 2 doses of rituximab. Repeat the course again.
Repeat the course again.
Actually, there is improvement by at least 25%.
I asked the same question to my clinic e-consult, because we have like sisterhood with them, and they advise in one patient to give 2 doses, 1 month apart, 1 gram, then after 1 month another gram, and 2 other doses after 6 months and after another 6 months. So it is 0, 1, 6, 12.
Probably, I'm not sure if they have like an observational studies that used this regimen. Probably, maybe they have an observational studies, but the recent RCTs actually, they used the regimen that I told you, Dr. Ahmed, the Mentor. They used the 1 and 6 if there is improvement, and the 1 and 8 days with 375 as in our cyclo study, as an iCyclo study. I have to say that we don't have, like huge number of patients in these studies. And that is why you're still gonna see some variability in the way of management of membranous nephropathy until we see like, evidence after evidence after evidence for rituximab. Then you will see like a standardized kind of care for lupus nephritis, for membranous nephropathy. Why we have now like a standardized kind of care for lupus nephritis, for the primary presenting lupus nephritis, because we have an accumulating evidence over years, good kind of evidence. We use either the Euro-Lupus protocol or MMF with clear timeline frame, I would say. It is not the case with membranous. It's still we don't have much number of patients, and that's why you see some variability in the management. But the good advancement now in the last a few years, that now we have a rule for rituximab, and that was based on RCT trials.
Okay, very good. Thank you, Dr. Muhammad. It was really a very nice presentation, We are so grateful to you. And now we will go to Dr. Ibrahim Razouk. Dr. Ibrahim, we have one missed presentation from the first day about probiotics, and we will start right now. Dr. Khurita, please, can you stop sharing your screen? Yes, please.
Bismillah. Assalamu alaikum wa rahmatullah.
Dr. Ibrahim, you can start sharing your screen, and we are with you for the next 20 minutes for the probiotics.
Okay, thank you. Again, thank you for organizing committee and of Saudi German Hospital, and thank you, special thanks for Dr. Ahmed for arranging this activity. Do you see my slide?
Not yet. I can see you and hear your voice clearly, but the slides not.
Okay, thank you. Okay. Now?
Just a few seconds. You can just, did we go through the same steps?
Okay.
Yes, exactly. It is coming now. It's coming now.
Okay. Yeah. Okay.
Okay.
Bismillahirrahmanirrahim. So just tackle this topic, which is commonly prescribed in the outpatient setting and commonly asked by patients and by healthcare providers. It's probiotics. There is no financial conflict to disclose. The probiotics first was described by Michenkov, a Russian scientist, and he's a professor at the Pasteur Institute in Paris. In 1908, he described these probiotics as live microbial food ingredients that alter the microflora and confer a health benefit. So the definition of probiotics, they are organisms that exert a positive influence on the health of the host animal. Probiotics or bacteriotherapy, as defined by the FAO and WHO, they are administered in both drug form and as a component of food and beverages. They are non-pathogenic living organisms that exert a positive influence on the health of host animal. The probiotics were defined as well non-digestible food supplement or ingredients, and they are not absorbed or degraded. They are not absorbed but degraded in the intestine and consisting of non-starch, polysaccharide, and oligosaccharide used as food ingredient. They stimulate the prebiotic. The prebiotic, I just mentioned the definition of prebiotics shortly, and the prebiotic, different from probiotics, prebiotics stimulate the growth and activity of certain species of bacteria in the colon. They are substrate of probiotics. Example of prebiotics, the oligosaccharide, inulin, garlic, onions, lactulose, whole wheat, and fiber supplements. Prebiotics presume to have health benefits such as promotion of growth of probiotics and production of short-chain fatty acid, increase of calcium absorption, as well as decrease in glucose absorption. Prebiotics compared to probiotics, they usually are carbohydrate. Not alive and beneficial, has a beneficial health effect, and they are incorporated as a food ingredient and act on microbiota and focus in the focus of action is on the colon. The probiotic, in comparison with the prebiotic, they are microorganisms. They are alive and beneficial health effect. They have food and dietary supplement, as well as they are incorporated in the drugs. And they may act on microbiota, but are different mechanism. They can act on numerous sites around the body compared to the prebiotic. They can act on the esophagus, stomach, small intestine, in addition to colon and rectum. Another type of the organisms are synabiotics, the combination of between the probiotic and with prebiotic food. So this improves the survival and colonization by probiotic. They are more effective than probiotics alone. So they have synergistic effect. In addition, there are some term called fermentation. As we know, this is a process by which microorganism transforms food into other products, usually through the production of lactic acid, ethanol, and other metabolic end products. The characteristic of effective probiotics, they survive in the stomach or gastric acid and bile and adhere to intestinal mucosal lining. They are non-pathogenic and non-toxic. They can grow and establish temporary residence in the intestine, and they can impart health benefits. There are different types of bacteria used as probiotics, such as Lactobacillus species and Bifidobacterium species. The other species include the commonly seen E. coli, Streptococcus, Saccharomyces, several combinations on the market. The potential mechanism of action of probiotics, they have possible modes of action. Through the inhibition of pathogen, including two basic mechanisms. And these called competitive exclusion and immune system modulation. The competitive exclusion involve the mechanisms such as production of inhibitory compounds, and that is hydrogen peroxide, bacitracin, and other defensin. In addition, the prevention of pathogen adhesion. They also compete for nutrients and reduce the toxin bioavailability. Meanwhile, in the immune system modulation, they have both innate and adaptive. They have both innate immune response and adaptive immune response. And they act by stimulating the beta cell and T lymphocyte. They also have, they produce, they act on the intercellular space and produce the mucus, as well as the intercellular, the extracellular space. They can be a receptor for the action of the probiotics and act through production of immunoglobulin, IgA, and other immunoglobulin. The clinical applications of probiotics, they have been used in diarrhea, acute infections, antibiotics associated C. diff, as well as lactose intolerance. They have been used in constipation, and they have been used in H. pylori eradication or side effect of antibiotics related to H. pylori eradication. They have also been used in Crohn's disease, ulcerative colitis, and the paucitis. So our main focus of the topic today is the probiotics role in the GI diseases. As I mentioned, diarrhea is one of the main indication of probiotics, and it has been confirmed that different probiotic strains are useful in reducing the severity and duration of acute infection causing diarrhea in children, but the evidence is mainly on viral gastroenteritis more than the other infectious agents. So treatment of acute diarrhea was based on 5-day therapy in Danish children aged from 9 months to 44 months in a daycare with acute diarrhea. The duration of diarrhea upon receiving the probiotics was significantly reduced in duration of diarrhea, but not that so significant in the watery diarrhea, and not so significant on duration of fever or after 120 hours. So prevention of acute diarrhea, also probiotic was used for that indication. And this diarrhea includes radiation-induced diarrhea, traveler's diarrhea, and the prevention of adult and childhood diarrhea. So there is only suggestive evidence that Lactobacillus GG, this GG is the substrate of the lactobacillus species as well. They are effective in some specific setting. Antibiotic-associated diarrhea. One study indicated that Lactobacillus casei is effective in hospitalized adult patients for preventing antibiotic-associated diarrhea and C. diff diarrhea. So probiotics for the prevention of antibiotic-associated diarrhea the studies were published showing some of the probiotics used the microorganisms such as Saccharomyces boulardii and Lactobacillus rhamnosus, and single strain probiotics, mixture of two probiotics, and they have a significant p-value in reducing the or preventing antibiotic-associated diarrhea. The Streptococcus boulardii was also effective in patients with recurrent C. diff disease. The initial C. diff disease showing that it's better than placebo when comparing with the patient who received the probiotics. It was not that significant, but it was significant preventing the recurrent C. diff diarrhea. For eradication of H. pylori, certain probiotics may help as adjunct therapy with antibiotics in the eradication of H. pylori infection. Several lactobacilli and bifidobacterial strains reduce the side effect of antibiotic therapy and improve patient compliance. Many patients do not complete their course of antibiotics for H. pylori. So some studies supporting the use of adjunct therapy of the probiotics together with the combination of multiple antibiotics in order to help patient compliance. So meta-analysis of 14 RCTs suggests that supplementation of anti-H. pylori antibiotic regimen with certain probiotics may be effective in increasing eradication rates. There is no evidence to support that probiotics alone without concomitant antibiotic therapy would be effective. Probiotics in IBS diarrhea or constipation. IBS range of symptoms such as abdominal pain, altered bowel habits, bloating, and flatulence in the absence of structural abnormalities in the intestine. studies observe alteration in the intestinal microflora in patients with increased symptoms following enteroconvection. Therefore, probiotics may be useful a tool, maybe a useful tool to improve symptoms. Reduction in abdominal bloating and flatulence as a result of probiotics treatment is consistent finding in published studies. Some strains may ameliorate pain and provide global relief. Lactobacillus reuteri may improve colicky symptoms with 1 week of treatment. So this is the multiple RCTs were performed to show the benefit of probiotics in IBS. These studies include, they are randomized controlled trials, but many of these, unfortunately, they did not specify which IBS subtype. For example, the first one was, they did not mention the subtype of IBS. In addition, the other study did not show any difference between the is it diarrhea or constipation. On the other hand, there is no clear dosage of the probiotic used. There's lack of information in the other studies related to the placebo, or is it comparing placebo or comparing dosage forms? There is no clear, though that they have mentioned it's double-blinded RCTs. In addition, the other studies were conducted on animal and not human being. So the lactose intolerance was also one of the focus of research in using probiotics, mainly Streptococcus thermophilus and Lactobacillus delbrueckii subspecies. They found out that it improved lactose digestion and reduced symptoms related to lactose intolerance. However, in necrotizing enterocolitis, seen mainly in the children group, probiotic supplement reduced the risk of necrotizing colitis in preterm neonates, and systemic review of RCTs have also shown reduced risk of death in probiotic treated groups. Probiotics was also used in inflammatory bowel disease, mainly is ulcerative colitis, or various probiotic species, and showing promise in management of UC. Prevention of relapse is more clinically documented than treatment of active disease, mainly paucitis. So with the other study did not show any significance of use of probiotics to treat inflammatory bowel disease. So the following are illustrative clinical trials related to use of probiotics inflammatory bowel disease. So they found out E. coli was as effective as low dose 5-mesalazine in preventing relapse of UC, and the combination of probiotics plus mesalazine was slightly more effective than mesalazine alone in mild to moderate ulcerative colitis. The combination of pre and probiotics or bifidobacterium was associated with improvement in histologic scores and immune activation in 1-month randomized controlled trial. This is the studies which shows the health benefits of probiotics in ulcerative colitis. The probiotics in Crohn's disease, also studies proved the prevention effect of lactobacillus on the appearance of recurrent lesion of Crohn's disease after surgery. Probiotics and paucitis is non-specific inflammation of the ileal reservoir after ileoanal anastomosis for UC. Disturbances in the intestinal microflora may be the triggering factor in its pathogenesis. There is a good evidence for usefulness of probiotics in preventing initial attack of bronchitis and preventing further relapse of bronchitis after the induction of remission with antibiotics. Probiotics can be recommended to patients with bronchitis of mild activity or as a maintenance therapy for those in remission. Probiotics also have been seen in preventing colon cancer. The SINCAN study tested the effect of oligofructose plus 2 probiotic strains in patients at risk of developing colon cancer. The results suggest that symbiotics, as we mentioned, prebiotic and probiotic preparation can decrease the expression of biomarkers for colorectal cancer. NAFLD, or non-alcoholic fatty liver disease, patients have used also probiotics, and they have shown improved inflammatory score as well as steatotic and peroxidative factors, in addition to the serum liver enzymes. Hepatic encephalopathy, and evidence obtained from clinical trials suggests that probiotics were able to decrease serum ammonia level and improve neuropsychological symptoms. The possible mechanism include reduction of bacterial urease activity, alleviation of pH ammonia absorption, and decrease intestinal permeability. The probiotics bind toxins and carcinogens, and some experimental evidence suggests that probiotics could be used to bind and immobilize toxic compound within the gut lumen. Through its process, the negative effect of dietary toxins could be reduced and gut and liver health improved. In vitro, Lactobacillus rhamnosus GG is able to bind mycotoxins known to interfere with this intestinal mucosal barrier. The claim also was for vitamin production. Probiotics have the capacity to synthesize vitamin, mainly vitamin K, folic acid, and B12. So these are the example in the market of forms of probiotics. It's mainly dairy products as well as yogurt and biscuit or candies. They have been added into the daily food for the kids, for the adult, and for different categories of patients. So what to choose now? Numerous preparation on the market. Which species is best? Are combination agents better? What is the appropriate dose? What is the appropriate duration of treatment? However, the probiotics has also its drawbacks. First, it's not FDA regulated. The quality control is poor. The probiotics taken orally can be destroyed by acidic conditions of the stomach if it's not well formulated. Food forms should be kept in the refrigerator. And to date, no generalization can be made from the health effects of one probiotic strain to another, and this remains a serious problem within the probiotic research field and its application. It's also difficult to determine the pathogenicity. Some strains have very bad effect on human health. They have virulence factor for pathogens like adherence, colonization are common in probiotics. Probiotics are microorganisms and can harm also the individual. The required dose of probiotics vary greatly for different strain and specific desired health effect. May need several months of therapy to see an effect. So calculated, it can cause a high economic burden and likely stop its action once discontinued. And side effects of probiotics are generally safe. They are generally safe and well tolerated. But rare cases report bloating, flatulence, non-specific symptoms. People having underlying disease or compromised immune system, probiotics can cause potential health problems, like immune compromised patient who are receiving immune modulator or patient who have already cancer. Invasive lactobacillus infection can cause bacteremia, skin rash, fever, bloody stools, endocarditis, and liver abscess. So we follow the recommendation of internationally accredited society like gastroenterology, American College of Gastroenterology, who put their who just mentioned the statement about role of probiotics in the management of gastrointestinal diseases. So their statement in adult and children on antibiotic treatment, they suggest use of Saccharomyces boulardii or Streptococcus boulardii or combination over no or other antibiotics for prevention of C. diff. Patients who place a high value on the potential harms, or like patients who have severe disease, severe illness, or high value on avoiding the associated cost, and a low value and the small risk of C. diff development, would reasonably select no probiotics. In patients with C. diff infection, they recommend the use of probiotics only in the context of clinical trial. In adults and children with Crohn's disease, the American Gastroenterology Association recommends use of probiotics only in the context of clinical trial. There is no recommendation due to gap knowledge or knowledge gap. So there is no recommendation in Crohn's disease. In adults and children with UC, they recommend the use of probiotics only in the context of clinical trials. So skip UC in general for children and adults. In adult and children with paucitis, this might be a little evidence to suggested use. We suggest the 8-strain combination of lactobacillus, and many species have been recommended to be used in this category of patient over no or other probiotics. Symptomatic children and adults with IBS, they recommend the use of probiotics only in the clinical trial, so no recommendation. In children with acute infectious gastroenteritis, they do not recommend use of probiotics. In the preterm, low birth weight infants, we suggest using a combination of lactobacillus species and other probiotics or other microorganisms for prevention of necrotizing enterocolitis over no and other probiotics. In order to be a standard probiotic, it should have standardized protocol. It should have large study, and it should have defined outcome together with correlation of symptoms. What is the aim of use of these biotics? Is it to relieve the symptoms or to relieve biochemical or other aims? So take home message, probiotics are living microorganisms with multiple mechanisms of action. They have good safety profile and many beneficial effects in GI, hepatology, and many other systems. And to confirm the effect of these products, more availability of clinical trial in various countries with disparate races, ethnicity, and lifestyle would be required. Thank you very much.
Thank you, Dr. Ibrahim Arzouk, for this interesting topic. We have one question here. Do you recommend rifabutin and probiotics for H. pylori eradication?
Well, from my clinical experience, I sometimes give the probiotics in patients who fail to tolerate the side effect of treatment, though the evidence is not strong. But I've seen some patients tolerate the antibiotics. So I would give the antibiotics together with the probiotic.
Okay, thank you. Thank you for this nice presentation, and please stop sharing your screen.
Sure.
Okay, thank you. And now we started yesterday one presentation about hyperkalemia, and today we will continue the management of chronic hyperkalemia. Thanks for staying with us. I am Dr. Ahmed Al-Ghitani, nephrology consultant in Saudi German Hospital, Riyadh branch. Yesterday, we talked about management of chronic hyperkalemia. I will go through the pathophysiology again for those who didn't attend yesterday. We are talking about potassium homeostasis. Most of the potassium ion is intracellular, and only 2% is extracellular. And to manage the level of potassium in blood, we have to think about potassium intake and the redistribution between extracellular fluid volume and intracellular fluids. This is managed by hormones and acid-base balance. And the output is 90% through the urine and only 10% through skin and gut. And in this, in managing the chronic hyperkalemia, we will talk about elimination of potassium out of the body through the GIT. Here again, this is the pathophysiology, what is happening inside the kidney and how potassium hyperkalemia may occur secondary to some drugs. Here is the glomerulus, proximal convoluted tubules, lobe of Henle, and distal convoluted tubules, and collecting ducts. If we have any drug affect impairment of release of renin, like non-steroidal, beta blocker, CNI, like cyclosporine or tacrolimus, diabetes and elderly, this will affect renin release, or allosterine, which is direct renin inhibitor, or ARBs or S inhibitors, or any drug will affect the aldosterone mechanism, whether on the receptor level or on the aldosterone itself. All these medications and reasons may cause hyperkalemia. Potassium is very important in the body for heart function, nerve impulse transmission, skeletal contractions, and enzyme functions. And hyperkalemia is defined as potassium more than 5, and it is mild hyperkalemia up to 5.5, moderate hyperkalemia up to 6, and severe over 6, and maybe life-threatening. Hyperkalemia is difficult to be diagnosed because in many patients it is asymptomatic or symptoms are non-specific, like having fatigue, weakness, palpitation, GI abnormalities, and some non-specific symptoms. Again, this is the ECG changes that may happen with hyperkalemia according to severity. We reviewed all this yesterday. Can we depend on ECG as a rapid diagnostic test? No, we can't, because some ECG changes are non-specific to hyperkalemia. Here is the level of potassium, whether low or high. With these comorbidities, it will increase the predicted probability of mortality. As we see here on the right side, having diabetes, heart failure, chronic kidney disease with high potassium, whenever the potassium is going more higher or below in severe hypokalemia, predicted probability of mortality is higher. And here is also in heart failure patients, risk factors for in-hospital mortality for heart failure. The most killing factor, or the most factors that has the highest hazard ratio, is hyperkalemia in comparison with other factors like ischemic heart disease and valvular heart disease. There is a great risk for hyperkalemia recurrence for those patients who suffer from even one attack of hyperkalemia, more than 50%, and some people may suffer from more than 20 recurrent episodes within 1 year. And the prevalence in chronic kidney disease may reach up to 55% in some clinics, with annual mortality about 25%. And these are the causes and medications that may cause iatrogenic hyperkalemia. We already discussed this yesterday, but just to review and start discussion about management. Why we cannot stop this medication which cause hyperkalemia? Because we are depending on RASi blockade, renin, angiotensin, aldosterone system inhibitors. It is the standard of care and the coronary stone in heart failure patients, and also in chronic kidney disease and in diabetic patients. If we will see these mega trials about ACE inhibitor, we have HOPE study where we have 3,500 patients. ACE inhibitor managed to make 25% reduction in combined outcome of MI, stroke, and cardiovascular mortality in diabetic patients, and 16% reduction in heart failure-related hospital admission and mortality. Also, ARCS in CHARM study, IDENT, and RENAL, you can see here the number of patients, about all in all, maybe reach up to 10,000 patients. There was a good benefit of using these drugs. 16% reduction in cardiovascular mortality, 23% reduction in risk of end-stage renal disease and diabetic nephropathy, and a 28% reduction in risk of end-stage renal disease and mortality. Also, spironolactone or mineralocorticoid receptor agonist in RALS study and the emphasis have the same benefits. So these drugs, ACE inhibitor, ARBs, and MRAs are very important in the standard of care of our patients who are diabetic nephropathy, ischemic heart disease, heart failure. We have to use these drugs. We cannot stop. But if you see the same studies, how many of our patients who were involved in these studies suffer from hyperkalemia? As you see here, hyperkalemia rate on the left side of the table reach up to 38% in some studies, and 2.5% for severe hyperkalemia in emphasis study, and more than 6 severe hyperkalemia, 18.6%. So it is something we cannot ignore. But in the same time, we have to use these medications. Using these medications and suffering from hyperkalemia may make the treating doctor or the patient to stop or reduce and retitrate again the ACE inhibitor and ARBs. So we will lose the benefit of using them in the standards, in the standard doses that make the benefits. So now we are in a clinical situation where using RASi is associated with better clinical outcome. Using it and having side effects like hyperkalemia may down titrate or stop the RASi, and this will lead to worse clinical outcome because we lost these beautiful medications. So we have to think about a solution. So I just review what we discussed yesterday, and now we will discuss the management of chronic hyperkalemia. Chronic hyperkalemia is different from acute hyperkalemia. We all know we work in ER, emergency department. If we have acute hyperkalemia, maybe this patient has diabetic nephropathy, maybe it's renal failure, or taking supplementation. If you suffer from acute hyperkalemia, he will come to the ER, we will give intravenous calcium as cardioprotective and start working on redistribution of potassium from intravascular volume to the intracellular, just to make benefit and being cardioprotective, like using calcium, like using glucose insulin, and nebulized salbutamol. Then we will work at the end in this diagram, if you follow my arrow, to take the potassium out of the body by using diuretics, and maybe you will have to use hemodialysis. But what about chronic hyperkalemia? Low, mild, or moderate hyperkalemia, potassium between 5.2 or 5.5 or 5.5 to 6, and it is iatrogenic secondary to using RASi blockade. So first of all, we will have dietary consultation. to reduce the potassium which is available in all the dietary supplements and most of the food we are taking, especially banana and dates. Also, we will have to manage RASI therapy, whether to stop and retitrate or changing the dose. We have to use diuretic. Sometimes our patients may tolerate using diuretics for a long time or may not. And at the end, the best option here is using potassium binders. These are the foods that has high potassium, not only mild or moderate content, but high potassium. If you see, it is available in many of the foods we are using on daily basis. Let's talk about potassium binders. The first potassium binder, I think most of us know about it, but we are not using anymore, which is kayexalate, which is sodium polystyrene sulfonate. It is insoluble polymer, cation exchange resin that is used orally or rectally to eliminate potassium through using the gastrointestinal tract as a sink to attract the potassium and go out of the body and finally eliminate it in feces. But we have some side effects, whether mild, like diarrhea, nausea, vomiting, and loss of appetite, and some other side effects are serious, like ischemic necrosis of colon due to concomitant use of sorbitol and its own content of sorbitol. Also constipation, seizures, confusion, muscle weakness, abdominal pain, and irregular heartbeats. And for muscle weakness and irregular heartbeats, the reason behind this is hypokalemia. With using kayexalate, sometimes we suffer from iatrogenic hypokalemia. The other option is calcium polystyrene sulfonate. We substitute the sodium content with calcium. This was beneficial because we reduce the salt load in patients with chronic kidney disease, patients with low GFR, but in the same time we give calcium. Okay, it is the same dose like kayexalate or sodium polystyrene sulfonate, but have some side effects like drug-drug interaction, reducing the absorption of some drugs, and also sometimes it causes hypokalemia, hypercalcemia, and history of hypersensitivity to polystyrene sulfonate ions. With obstructive bowel disease, we cannot use it. And with patients, many of our patients are diabetic, they have low motility, we cannot use calcium resonium in these cases. The new option is zirconium cyclosilicate. It is a new drug working on the same fact that we have to eliminate the potassium through the gut. It is microporous zirconium cyclosilicate compound, insoluble, not absorbed at all in the body. And you see here, it has 9.3 times potassium binding capacity. The affinity of this compound to potassium is 9.3 times kayexalate. In the same time, it is 125 more selective to potassium. We suffered from sodium polystyrene or polystyrene compounds, whether sodium polystyrene or calcium polystyrene, that it can cause hypomagnesemia, hypocalcemia, and interfering with other elements because it is not selective to only potassium. Sometimes it eliminates more ions like potassium. But here the affinity and selectivity of zirconium cyclosilicate is evident. We have this study, dialyzed study, about 200 patients with end-stage renal disease. They are doing dialysis 3 times per week with adequate dose of dialysis and sufficient dialysis, but they are still suffering of hyperkalemia. We used the zirconium with one limb, and on the other side, we used the placebo. And you can see here in the middle of the screen with the arrow that 41.2% with zirconium, they achieved the required potassium level, while with placebo, only 1% achieved this. And also side effects were not that significant with zirconium, but we have to look at the last one, weight gain, intradialytic weight gain, because zirconium contains sodium, and I will discuss this later. Here's a graph showing before and after zirconium, how much potassium before and after in pre and post dialysis. We have many trials about zirconium to prove its efficacy and safety in renal patients and even non-renal patients. But I will not go through all of it because of the time factor. So this is one study, another one, Energize, and at the end I will give you the conclusion of using zirconium. It is safe with reported hypokalemic incidence about 4%. Edema-related events, we have to concentrate here. Edema-related events, it's about 5.7% because of its sodium content. Hypokalemia, some interactions with some drugs, that's why it is administered 2 hours before or 2 hours after the medications. And it contains 400 milligrams of sodium per the 5-gram dose. The other competitor is Patiromer. Patiromer is the same. It is non-absorbed cation exchange polymer working in the gut to attract potassium and eliminate it out of the body. We have some clinical trials about its safety and efficacy. As you see, with use of spironolactone, patients could achieve normokalemia with using of Patiromer, but with placebo they couldn't. And here is the graph. The potassium level with placebo was high, but with Patiromer it is low. This is the efficacy trial. And the other trial here was on diabetic kidney disease, and it was used for 52 weeks to prove the efficacy and safety and to monitor the side effects. And more or less, there was a very good efficacy. As you see here, potassium, whether the red line was patients suffering from moderate hyperkalemia, and the blue line was the patient suffering from mild hyperkalemia. Both of them were maintained in the hypokalemic, in the normokalemic range with using Patiromer for 52 weeks. At the end, Patiromer can be used in the same indications of hyperkalemia like zirconium, and it has some side effects like constipation, hypomagnesemia because of the selectivity issue I discussed before, diarrhea, abdominal pain, flatulence, hypomagnesemia and hypokalemia still the main side effects because of its non-selectivity in comparison to zirconium. And here this table shows the difference between the 3 compounds, whether cholesterines, Patiromer, and the zirconium. Patiromer is faster, has faster onset of action, more sodium content, less calcium, and no sorbitol content. And on the other side, it's a competitor Patiromer, better action than polystyrene compounds, but it contains more calcium and more sorbitol, but less sodium. And the affinity, as I said before, zirconium has more affinity to potassium than Patiromer, and that's why it doesn't cause hypomagnesemia or hypocalcemia like the other compound, which is Patiromer or polystyrene. So we can use mineralocorticoid, anti-mineralocorticoid, S inhibitor, ARBs, or beta blocker that way may make a problem to this poor guy, which is a potassium, but potassium binder will solve the issue. In 5 minutes, I will show you 2 of my cases who got benefit of potassium binding. The first case, female patient, 30 years old. She had been on dialysis for the last 10 years on hemodialysis. She's non-lupus and antiphospholipid syndrome and was referred to our Center for Management of Failed Vascular Access. She suffered from superior vena cava thrombosis, bilateral femoral vein thrombosis, and she was referred to us for inserting translumbar or transhepatic permicast. But it will not be done after reversal of anticoagulation effect because she was on anticoagulant. And the patient refused peritoneal dialysis. In this case, her potassium was 6.6 and she has hyperkalemic changes. We used Patiromer in this case and intravenous calcium, and her potassium was controlled only with use of potassium binder. The other case was 58 years old male with long-standing diabetes, heart failure, Epstein anomaly, and chronic kidney disease stage 5. He was using metoprolol, irbesartan, metolazone, and Lasix. And on presentation to our hospital, he was conscious, alert-oriented, and orthopneic, congested neck veins, moderate ascites, lower limb edema. He was in volume overload status, and his potassium was high, secondary to using mineralocorticoid antagonist and ACE inhibitors. His diet was revised, and we managed the acute setting of hyperkalemia, but still the question was raised, how to manage hyperkalemia as a chronic problem in this case. So he refused to start dialysis. We increased the dose of Lasix. When we increased the dose of Lasix, potassium was controlled. It was 4.5, but the patient was confused. What was the reason of confusion? Sodium was 110. Using diuretics make us control the potassium, but we couldn't control sodium. And many of our patients who are coming for emergency department suffering from hyponatremia are secondary to mega doses of diuretics. So in this case, we reduced the Lasix again, and we started potassium exchange resin, and this case was managed successfully without the use of dialysis. Thank you. I can't see any question about this. Thank you for attending my presentation, and now we will go for another presentation with Dr. Abdulaziz Al-Abdelali, a consultant hematology, and he has a long experience with hematology. And me, myself, I can't wait to hear his presentations, and I am sure that we will enjoy this. Thank you, Dr. Abdulaziz, for coming here. And when and how? When.
Thank you, Dr. Ahmed, and the organizing committee, so the German hospital, the audience. To start, I'd like to apologize for everyone. I got my third shot yesterday, so I'm having some fever, myalgias, but I hope my tongue and my brain are still working. So let's go ahead with the presentation. It's about drugs. These are my disclosures, nothing to be clear. And we'll start with the introduction. And the objective really of this, or objectives of this presentation, is to know the contraindications, indications, importance of using a properly predictive scoring system for patients with non-valvular atrial fibrillation for stroke and systemic embolization, the CHA2DS2 VASC score, and managing patients with special characteristics and case scenarios, mostly those with interacting medications, elderly, obesity, renal impairment, and patients with high risk for GI bleeding. And to give a slide or two about the misbelief about compliance and using a single versus twice daily pill is better for patients who are anticoagulated. Then some slides about the how to choose among different drugs. So in medicine, we always try to find something that fits each and every patient, and this is not real life. Trying to apply this for anticoagulants, especially oral anticoagulants, definitely is failing, and drugs are not solving the issues with warfarin. Now, this is a case, progressive acute unprovoked VTE while on drugs. A young female recently married with oral contraceptive pills admitted with severe gastric pain. She had a history of small joint arthritis, so we should think of autoimmune disorders. Workup included CT that showed thrombosis. Normal white cell count, but the differential showed low lymphocytes percent. Normal microcytic anemia with mildly decreased platelets and high ESR. She was started on Xelerto, which is rivaroxaban, 20 milligram once a day, because it's a single pill, no testing, no follow-up needed. Easy life, which is not true. The pain continued, and 4 days later, developed chest pain, hypotension, hypoxemia, went to the ICU, intubated. She had pulmonary embolism. Later on, testing revealed lupus anticoagulants. True statements, failure of any drug in this situation. They are contraindicated in lupus anticoagulants. The dose was inadequate. When we start rivaroxaban, it should be 15 BID, not 20 once a day. Initial treatment should have been with low molecular weight heparin followed by vitamin K antagonist. This is another case that I saw, elderly male, 7 years history of recurrent unprovoked DVTs with PEs with significant pulmonary hypertension. He was stable, though, on warfarin and low-dose diuretics. But last year, for reason or another, ease of the so-called drugs, he was switched to a drug. Got worsening, right heart failure, pulmonary hypertension symptoms, significant shortness of breath. Echo showed severe pulmonary hypertension. No hypercoagulable or workup was done. So when it was done, he showed to be homozygosity for factor V, Leiden, lupus anticoagulant, and hyperhomocystinemia. So true statements. Again, drugs should not be used in such a patient, but rather either low molecular weight heparin or vitamin K antagonist. Clearly, the deterioration of patient pulmonary hypertension is caused by drug. And in clinical practice, whenever there is an unprovoked DVT, we should perform hypercoagulable workup. Now, this highlights the issue of compliance, because it's always around that drugs increase compliance. Single pill is better than twice a pill a day. Look at this patient, 70 years old, male, diabetic, hypertensive, dyslipidemia, ischemic heart disease, and his primary care physician is always having an issue of compliance, which is a common thing to happen with this age group. Recently diagnosed with non-valvular atrial fibrillation. So his family physician started a single daily oral drug, hopefully to increase the compliance. So all the following statements about drugs are true. Compliance with drugs is never, and this is very important, is not better than vitamin K antagonist. And I'll show you some data about that. Single daily drug is not safer than a twice daily drug in case of missing or doubling the dose. I'll show you some data. This is the Dutch Foundation Pharmaceutical Statistics run this retrospective survey 2012 till 2016, patients with VTE, which is short-term anticoagulation. It's not like atrial fibrillation. It's a quite good number. And look at the discontinuation rate. 20% of patients on drug, they stop the drug, while the ones on vitamin K, only 9% stop. This is probably that because of the INR. You always see them in the clinic, you counsel them, you advise them, you educate them. That's why you increase the compliance. Just filling a prescription for drug, going home, that does decrease compliance. Now, this graph shows difference between a BID dose or a single daily dose. Look at the A, which shows the graph of the blue is a once a daily pill, as opposed to the red twice daily. But they're all in the, when they are taking in the right time in the therapeutic level. B, when you miss one BID dose, the trough is not terribly low. But look at C, when you miss one single daily dose, it equals to missing 3 BID doses. This is very risky, especially for patients with high thrombotic risk. Again, in D, if by mistake take an extra dose, the anticoagulant effect of a single daily dose will be very significantly high, which will increase the chance of bleeding. So a BID dose is better than once a daily dose. Now, what about INR? This is a patient who came into the emergency room. He's having an non-valvular atrial fibrillation since 1 year on DUAC, doing very well. Last dose was taken 10 hours ago. He's having right-sided weakness. And his workup showed left MCA ischemic infarct without any hemorrhage. He had normal CBC, INR, BTT, and creatinine. He was given thrombolytic as if he is like all other patients who are, let's say, on warfarin. The criteria here in this situation is totally different. Next day, he was having hemiplegia and aphasia with hemorrhagic transformation. So true statements. Never use INR or BTT to look for the effect of a DUAC or to monitor a DUAC. And the presence of a normal BTT INR does not exclude presence of a full therapeutic level of a DUAC. And look at the recent guidelines. Patients who are receiving DUACs should not receive thrombolytic therapy within 48 hours, provided their kidney function is normal. If it is abnormal, you may need more than 48 hours. Look at how we risk assess patients with non-valvular atrial fibrillation and the importance of using this scoring system, which is CHA2DS2 VASC, rather than the old CHAD2. Elderly, female, history of MI 5 years ago, treated medically without stent, on aspirin only. Recently is having non-valvular atrial fibrillation. True statements. Can we use just aspirin in this case because she is having low CHA2 score, or oral anticoagulation without aspirin, or together? Now, if we use the CHA2DS2 VASC score, she will score 3 as opposed to 0 by the old scoring. And she has an intermediate risk, so she must be anticoagulated. But with the old score, she doesn't need anticoagulation. And she has a 3.2% risk of thromboembolism annual. Okay. I'll leave the choice of the medication at the end. And when you look at the ACCP or ASH American Society of Rheumatology or ISTH, International Society of Hemostasis, they mandate or recommend the use of this score system rather than this scoring system. Just quickly, the score system is 8 variables, and you will get, then you will count the numbers. You will get 0 low, 1 intermediate, more than 2 is high, as opposed to the old scoring system. And this is a very good example, like the one I showed you before. 70 years, female, history of MI. By this scoring system, she's 0. But if you use this one, she has a 3, and she should be receiving oral anticoagulation, provided no other contraindications. Whenever you try to start, or you plan to start patients with oral anticoagulations, always try to assess his or her bleeding risk. One of the most common scoring systems is the HAS-BLED. There are other systems that are scoring system used for this, much more complicated than the HAS-BLED. There are on the iPhone, you will find all these scoring system for ease of use. Now, these are the guidelines for non-valvular atrial fibrillation, especially from the ACCP. We must use CHA2DS2 VASC for risk assessment. Low risk patients should not be offered thrombolytic therapy, and this low risk is 0 in a male or 1 in a female. More than that, they should be offered oral anticoagulation. On the other hand, we should not use just antiplatelet therapy like aspirin alone or with clopidogrel for stroke prevention. An update of these guidelines, 2018, regarding the drugs. The ACCP, they mentioned that we recommend drugs over vitamin K antagonists. And I'll show you some data about that, why this recommendation is. But in patients with consistently low time in INR therapeutic range, it's advisable to switch them to a drug rather than keeping them on warfarin. TTR is time in therapeutic range. This is the times that the percentage of the times in a given year that your patient INR is therapeutic between 2 and 3, not below and not high, and should be properly 65 and above. I will come to this. It's very important in the drug situation. Trials. Those with unprovoked warfarin-associated bleeding or at risk of bleeding, the suggestion is to use apixaban, edoxaban, or dabigatran 110 milligram. These are the ones associated with the lowest risk of bleeding, as opposed to full dose dabigatran 150 or varoxaban. In the European side, they prefer drug of vitamin K antagonist in the prevention of stroke and atrial fibrillation, especially if newly initiated. But if the patient is already on it, well controlled, good TTR, one option is to keep him on the warfarin. So a quick assessment of your patient, whether he or she needs anticoagulation or no for this situation. 3 main questions. The first question, if the patient age is more than 75, must be on oral anticoagulant. If less than 75, if there is a history of TIA or stroke or embolism, need to be on anticoagulation. If none of these are there, then if there is any of the following, age 65 to 74, hypertension, vascular disease, CHF, or DM, need to be on oral anticoagulation. Otherwise, no need for oral anticoagulation. This is in a stepwise fashion. Generally, when you are faced with a patient who needs to be on oral anticoagulation, the first step, as we talked before, we need to decide, does he need? If he's low risk, no need. And we stop. If it's moderate to high, yes, they need. Then we need to determine the bleeding risk. As I said, one of the most common scoring systems is the HAS-BLED scoring system. If it is low, then we go to the third step, which is, should I use a drug or vitamin K? If it's high, I need to try to manipulate this increased risk, whether it's hypertension, labile ANR, non-steroidal, antiplatelet, alcohol consumption. So once I decide about drug or vitamin K antagonist, the next step, which was really very challenging, is there one drug better than another. Don't forget to keep following up, monitoring. All this process ideally should be within a designated anticoagulant surface. These medications are high-risk medications. So these are the different indications for direct oral anticoagulants and low molecular weight heparin and vitamin K. All of them are indicated in stroke prevention, non-valvular atrial fibrillation, DVT treatment, or the secondary prevention. In the case of mechanical valves and VTE prevention after HAP, only molecular weight heparin or vitamin K antagonists. Prevention of DVT in the orthopedic setting, all of them, dabigatran only HAP, not in the knee. Mention my mechanical valve, acute coronary syndrome, we have rivaroxaban, low molecular weight heparin, vitamin K antagonists. These are approved, others are not. Also the cancer, prophylaxis, VTE prophylaxis or treatment. Now, in the ICU, none of these are advisable. Also in the acutely ill patients, there is an approval for rivaroxaban in this setting. I'll come to it later. There are lots of contraindications. And we should start with these contraindications before the indication to ensure that my patient is not having a contraindication. Pregnancy, lactation. Pediatrics used to be a contraindication. Last year, end of last year actually, dabigatran and rivaroxaban got FDA approval for use in pediatrics. Hypersensitivity, prosthetic heart valves, mechanical, active bleeding, acute kidney disease, patients on dialysis. And I'll speak about the chronic kidney disease later on. Be careful in liver impairment, significant severe pulmonary embolism, where there is instability and there is need for thrombolysis or embolectomy. None of these should be used. Severe hypercoagulable states, antiphospholipid or homozygosity. This is a contraindication for drugs. Now, just show you, I'll try to concentrate on the use of drugs in non-valvular atrial fibrillation, because this is the one you're facing always. And this is the one that has lots of issues around, especially when it comes to promoting one medication over that. These are the 4 pivotal randomized trials, non-valvular atrial fibrillation, looking at 4 medications. Apixaban, twice a day, 1 dose. Rivaroxaban, 1 dose daily, single dose. Dabigatran, 2 doses, a high and a low. Edoxaban, also 2 doses. Now, all these trials, the design was first not a superiority, but rather a non-inferiority hypothesis. And this is probably because there's a perception that the magnitude of the benefit is not terribly high. So they found that all of them, they are non-inferior to warfarin. Then they run a test of superiority. So only apixaban and dabigatran 150 passed the test of superiority. Others did not. So they're not superior to vitamin K antagonist. Only dabigatran 150 and apixaban. So in short, if you have a patient with an non-valvular atrial fibrillation, will you give him a medication that is superior in preventing stroke or a similar to warfarin? You will go ahead with the superior. One of these 2 medications, apixaban or dabigatran. The next step really is to see the side effect, which is the major bleeding, because the major bleeding may be so severe that it will overcome the benefits of the preventing the stroke. And again, only apixaban came superior to warfarin in terms of bleeding. The other 2 similar effect, but with this lower dosages. So they lose the antithrombotic effect. So as a start, or at first glance, I would use a medication that is superior in preventing stroke and decreasing bleeding, which is apixaban. The second choice will be dibitrab, then high dose or low dose, or rivaroxaban, low dose. The last is rivaroxaban. But mind you, we should put this in the context of the final patient outcome, what we call a net clinical benefit, and I'll come to it after a while. Now, this is a patient 70 would highlight two main issues that I will explain to you or discuss with you. Elderly female, hypertension, diabetic, heart failure, history of TIA, aortic plaque, just diagnosed with non-valvular atrial fibrillation, normal liver and kidney, very high score for embolism and stroke, and also high score for bleeding. So what to give this patient? Warfarin, rivaroxaban, because she has high score, dabigatran, because she has high score and it's highly effective, or apixaban. Now, when we look at these trials, you will find in the literature always papers about how to choose your anticoag, which drug. And there are certain points that authors go through. There are 2 points which are very general: the bleeding risk and the effect on renal, or the use in renal impairment, where apixaban is much more safer in this situation. The other point, which is always difficult to discuss, and you find all the pharmaceutical representatives are promoting, is high risk patient for thrombosis should be either on rivaroxaban or dabigatran. Why is that? Let's go with rivaroxaban. This idea came because when you look at the patient's characteristics in these 4 trials, the Rocket AFib, which is rivaroxaban, more patients having higher CATS score than the other trials, or prior stroke, or heart failure, diabetes, or prior stroke. So they assume that, okay, your patient is having a high CHADS score, put him on rivaroxaban. How true is that? Look at the absolute number of embolic events per 1,000 patients in all these trials. This is the rivaroxaban. One thing is that the numbers, the absolute numbers, are staggeringly high, 3 times to 4 times than in the other medications. It's not only that, even warfarin in the rivaroxaban trial is worse than warfarin in any other trial. Okay, and if rivaroxaban is going to work in the high risk, look at the subgroup analysis of each and every trial. Those with low CHAD score compared to those who are having high CHAD score. Rivaroxaban didn't do well compared to warfarin. And a matter of fact, when you see the numbers of rivaroxaban, it's even worse than the numbers of warfarin in the other trials. Even the presence of a previous stroke, which is the highest risk predictor for repeated stroke. Okay, patients on rivaroxaban didn't do well. Before I leave this, when it comes to CHADS, see the low risk. Dabigatran 150 did very well, very low number. So 1 single digit, 7 events as opposed to that. But when it is high, it's like apixaban. Again, similar scenario when you look at it, patients with heart failure, hypertension, diabetes, or without, or prior vitamin K, use of aspirin, or age. So this is the rest of the patient characteristic. More or less, they are similar in all the trials. One important point, this is the TTR we spoke about previously. It should be 60 or more. Look in the Rocket AF where used rivaroxaban. Only 55% that they were really therapeutic. So the treatment with warfarin is very questionable in this trial, okay? And regarding consistency or compliance, look at the discontinuation at 2 years. Warfarin is 8. The discontinuation was 8%, more or less like apixaban, 7.6. Others are higher, especially with the dabigatran. The side effects with dabigatran are higher. Okay. Now, let's go to continue with the stroke. I'm sorry for paying more attention to the slides, but you will face this dilemma with your patients. Now, we said dabigatran, apixaban superior in terms of preventing stroke, but apixaban is superior in terms of major bleeding. When you look at this stroke, there are 2 different kinds of stroke, either the ischemic, preventing the ischemic, or the hemorrhagic. And the main effect of the new drugs is really in decreasing the hemorrhagic stroke as opposed to warfarin, not preventing the ischemic one, except dabigatran. So here, dabigatran, there is a valid point for using it in a patient with high risk stroke, but mind you, with a very low bleeding risk. Otherwise, you need to go to the apixaban. And most of the bleeding really is GI. Major GI is very significantly high in rivaroxaban and dabigatran, worse than warfarin. This is the concept of net clinical benefit. We should not look at just preventing an ischemic stroke, but we should look at also the whole patient, hemorrhagic stroke, MI, major bleeding, all these together. Now, this concept is the basis of this paper, which looked at the rate ratio of each and every one, combine them together, and they give a weight for each and every event. This is how it is affecting the patient clinically. And in short, when you combine ischemic stroke, hemorrhagic stroke, myocardial infarction, systemic embolization, and adjusted major bleeding, you add it to cardiovascular mortality. Dabigatran beneficial benefit over warfarin is 10%. At all-cause mortality, 9%. So apply it to every one of the medications. The best or the highest with the benefit is apixaban. You get 19% improvement. Then edoxaban, the 30, you get 15%. Then the edoxaban 60, you get 13%. Now, number need to treat, but I'll leave it later on if we have time. So let's go to the elderly population, where we always have a fear of giving them a medication that we cannot test or know what is anticoagulant effect. This is an 80 years old female hypertensive ischemic heart disease, well controlled on aspirin, admitted with mild left arm weakness and palpitation, diagnosed with non-valvular atrial fibrillation and right MCA ischemic stroke. NIHSS4, which is moderate, normal renal and hepatic. So the team are asking, should we just keep her on aspirin or a drug or warfarin? This is the data from Medicare, Medicaid services that looked at more than 11,000 patients, elderly, median age 80, survival of ischemic stroke, and they were treated and sent home. They looked at the primary outcome, time in home, and major adverse cardiovascular events, whether they are on a DWAC or warfarin. This slide shows you that patients on DWAC did better than warfarin in all patient categories. So it's better to put them on DWAC. Now, the cardiovascular events also, patients on DWAC did much better than warfarin. So again, this is reassuring for us. This is a GI consultation. Dr. Nasser is here, so he will help us. 66 years old female, hypertensive, diabetic, peptic ulcer disease 5 years ago in a PPI, admitted with non-valvular atrial fibrillation, has normal liver function, creatinine, though, is 40 ml per minute. CHAD score is 3, HASBIT 3. What would be the best anticoagulant drug we use in this patient? Warfarin or a DWAC? If a DWAC, which one of them? Again, data for very extensive, large number, 381,000 patients who are at least having one high-risk GI bleeding. And they are, the majority are more than 75%. More than 75 years old. And they're trying to compare warfarin to the DWACs. So compared to warfarin, when it comes to stroke, all DWACs were associated with a lower risk. So this is reassuring. Major bleeding. Compared to warfarin, apixaban, dabigatran were associated with the lower risk of bleeding. But rivaroxaban is associated with a higher risk of bleeding. So preferably not to be used in this case scenario. Now, when you look at the different DWACs, you try to compare them from this paper. When it comes to stroke and systemic embolization, apixaban seems to be better than dabigatran or rivaroxaban, while dabigatran is equal to rivaroxaban. Bleeding, apixaban is better than both. Dabigatran is better than rivaroxaban. So apixaban, dabigatran, rivaroxaban on the bottom. Kidney disease, chronic or acute. This is a patient, again, chronic renal impairment, creatinine 25 ml per minute. Admitted with worsening renal function due to dehydration, found to have non-valvular atrial fibrillation. True statements. DWACs cannot be used during acute stage of renal disease. That's true. They shouldn't. They're not approved. During his chronic renal stage, apixaban can be used. With this creatinine clearance, yes. With end-stage renal disease or renal replacement therapy, use of apixaban low dose 2.5 PID is controversial. And I'll show you some data. This graph, I got it from the EHA Heart and Rhythm paper. It's open access, you can access it. Very helpful paper. Just show you different dosages of different DWACs with a different creatinine clearance. So whenever you are planning to prescribe a DWAC, you need to pay attention to this. Now, when it comes to using DWACs in renal impairment, the issue is very complicated, and you have too much different guidelines. To one side, not to use any anticoagulation, I listed them here, or aspirin. to the more extreme, where you can use apixaban without adjustment in patients with their own dialysis. But this issue hopefully will be sorted this year. We have these four randomized trials that are running that would address this issue in patients with chronic kidney disease, which they are very peculiar patients when it comes to anticoagulate them. And one of the other measures to think of is really what is these patients or patients who are at risk of bleeding or bleeding and you cannot start them on anticoagulant again, is to think of what is called left atrial appendage closure with your senior cardiologist. So we're reaching the end, hopefully. What about obesity and bariatric surgery for having non-valvular fibrillation or VTE and they need anticoagulation? What is the situation of the drugs in this situation? This is a young female, diabetic atrial fibrillation on rivaroxaban. Her weight is 140, BMI 48 with sleep apnea. She had prophylactic vaccine 40 milligram only, very bariatric. Day 5 developed DVT, treated with full dose Clexane, then warfarin. Requirement of high dose warfarin. They cannot keep up with warfarin dose to reach a therapeutic INR. Was blamed to her being non-compliant and referred to psychiatry and switched to rivaroxaban. 15 days later, she developed PE. So, true statements. Pre-op intermittent pressure compression and post-op Clexane 40 to 60. That is the recommended in this weight rather than just 40. So it should be BID rather than once a day. Patients with obesity, rivaroxaban, apixaban are reasonable for non-valvular atrial fibrillation and treatment of VTE, provided they are given in the right dose. But what about bariatric? It's contraindicated to use. Once patient is undergone bariatric, they have degree of malabsorption. They will not absorb adequate drug. The same thing, she was not absorbing adequately the warfarin. So it was not a compliance issue. It wasn't that she needs psychiatric help, but she needs really to have higher dose of warfarin. This is the guideline, 2021. Find it in Journal of Thrombosis Hemostasis, looking at the issue of obesity and bariatric surgery, exactly what we just said. So, optimal use of drugs. When they are optimally used, they increase efficacy and safety over vitamin K antagonist. This optimal use requires that we use it in approved indications without the presence of contraindications. Assessing bleeding risk, patient's antiplatelet, GI, liver. Proper dosage per indication. I will come in the next presentation about different dosages. Proper dose per age, weight, and renal function. Continuously search for drug interactions. Every day and now, we get new information about drug interactions, which thought to be no interactions. Choosing amongst drugs is the most effective. Choose among the drugs the most effective and safe. Proper administration, so with food or crushing. You need to see in your hospital whether you have a reversal agents. And this should do it with the first presentation. Thank you. So, نمشي للثاني.
يلا وين طيب ما طلع شيء. يلا كيف اقدم هذا هذا. بسم الله الرحمن الرحيم. I am Dr. Mohammed Nasser, consultant gastroenterologist in King Abdulaziz Medical City. I'll be happy to share with you tonight's discussion about eosinophilic esophagitis. Eosinophilic esophagitis. As a pathological entity, it was in the literature between 1993 and 1994, with reports by Atwood and Stroutman. دي أبعد هذه كيف أبعد هذه؟ في كلام جنبها. أيوه كده. As the definition as exaggerated response of immune system to contact with allergens. A recent meta-analysis found that the incidence rate was 6.6 in 100,000 person years in children and 7.7 in 100,000 person in adults, and that prevalence was 34 cases per 100,000 children and 42 cases per 100,000 adults. It is more common in men with a male to female ratio 3.3 to 1. More than 65% of the cases occur during childhood, and there is a peak between 3 and 40 years of age. In a population study, higher prevalence of esophageal esophagitis has been found in Europe and North America, whereas the lower prevalence in Eastern countries, suggesting that there is associated with environmental and immune factor. Eosinophilic esophagitis is the more common in rural area with low population density, which may be explained by vegetation pollution and environmental, and it varies according to the climate zone and season, with more frequent during the summer. The hypothesis of hygiene and bacterial dysbiosis, that is modern life and hygiene condition, have been decreased the incidence of infection, resulting in less bacterial exposure and altering body microbiota and epithelial permeability. Environmental factors such as changes in aeroallergen, air condition, and concentration of the airborne pollen, and genetic and chemical modification used in the cultivation, processing, and packaging of food. Decreased frequency of infection by Helicobacter in certain countries has been found that bacterium increase T. helper 1 and T. helper 17 population, downgrading T. helper 2. Gastroenterological GERD is an entity lead to injury of intra-epithelial junction, injury of the intra-epithelial junction, causing a great allergic permeability in the esophageal epithelium as measured by mucosal impedance. Use of suppressive which is paradoxical, given that BBI exerts anti-inflammatory effect by blocking eotaxin secretion and inhibiting acid secretion, thereby reducing the activation of digestive enzymes such as the antigen in food. That antigen in the food do not degrade, and the digestive system is protected from immune response. The main food that induce immune response in patients with esophagus are milk, wheat, soy, eggs, peanuts, and fish and the shellfish. Theory that affirmed in study that removed those 6 food because of the observation and because it involved immune response mediated by T. helper 2 lymphocyte. This disease is considered from food allergy. Patient with esophagitis has genetic risk factors, genetic variant in gene such as CCL26, which encode eotaxin 3, thymic stromal lymphopoietin, filagreen, desmolagreen, that TSLP is an overexpression is overexpresses in epithelium of people who had AUE. AUE activate T helper 2 lymphocyte, which in turn activate basal. Lastly, secretion of interleukin 4, interleukin 5, interleukin 13, and CCL4. Activate the STATs and the STATs 6 pathway, where the latter of which in turn regulate very important molecules such as eutaxin 3, calpain 14, and desmoglerin. Interleukin 13 induce secretion of 2 molecules in the esophageal epithelium. First, eutaxin. In clinical practice, immunostaining for immunoglobulin G in esophageal biopsy has been effective in diagnosing of esophageal esophagitis, as it has low sensitivity of 48. Interleukin 13 play an important role in the epithelial lesion because it induces a decrease in flagellin protein that's present in the stratum corneum of the esophagus, thus allowing the passage of allergen, because this desmoglerin 1 decrease to the barrier function of the esophageal epithelium is also diminished. Once acute inflammation is established, several mechanisms are induced, causing chronic damage at the esophageal level. At this stage, tumor growth factor B induce periosteum, facilitating the remodeling of the esophageal level, as well as the increase in the smooth muscle and fibrotic tissue. School-aged children and adolescents present with symptoms such as dysphagia and food impaction, especially with food that is coarse consistency. Other symptoms that at this age are chest and abdominal pain, vomiting, and regurgitation. In adults, main symptoms are dysphagia and untreatable heartburn. Endoscopic finding in most patients with AUE include linear grooves on the esophageal wall, concentric rings which exudate that resemble Candida infection, Czasowski ring, a reduction in the size of the vesicles, and the specialty of mucosa after endoscopy. The AUE endoscopic reference score, the classification system for AUE, has been validated and include major esophageal features, rings, furrows, exudate, edema, as well as additional features such as narrow esophageal caliber, strictures, and creep paper esophagus. A meta-analysis of AUE endoscopic finding, including more than 100 population, comparing the total of 4,600 patients with AUE 2,700 control, found that the sensitivity, specificity, and the protective value of the finding in isolation are insufficient for the diagnosis of AUE. In the diagnosis of endoscopic appearance of esophagus may be normal in 10% to 25% with AUE. It is necessary to perform esophageal biopsy in patients who are clinical suspicion of AUE. Even if there is no endoscopic alteration of the esophageal mucosa, because esophageal infiltrate occur in batches, biopsy should be taken from upper, middle, lower thirds of the esophagus. Studies have shown that taking 6 to 9 biopsy increases sensitivity to 100%. A histological diagnosis, which is the most important thing that I have to say, is confirmed when there is more than 15 eosinophil per high power field. The degree of dilatation of intracellular space is inversely correlated with the measured mucosal impedance. Direct measurement of esophageal by measuring mucosal impedance can potentially obviate the need for endoscopic and repeated biopsy in AUE and the pH monitoring. The 3 of the S of the treatment of the drugs. GERD play an important role in the AUE because mild eosinophilia, 5 to 10% eosinophil, can also be found in biopsy of GERD patient. BBI increase the pH of gastric content, reducing the esophageal damage caused by exposure to acid. Additionally, they exert anti-inflammatory effect by blocking T helper 2 response with reduction in the inflammatory cytokines exposure, and they repair the epithelial barrier of intracellular space that is altered by acid exposure. BBI are first-line treatment for patients with EUE. Initial doses 20 to 40 daily. In a study included 100 patients with EUE, 33% reached remission, sustained clinical and histological with less than 15% of eosinophil after taking 40 milligram of BBI for 8 weeks. After reducing the dose of omeprazole to 40 milligram, 81% remained in complete remission. And of those, the 83 remained even with just 20 milligram BBI. That observation supported another study of 5-3 patients who, with the expression of eutaxin 3, interleukin 13, interleukin 5 in proximal and distal esophagus, was evaluated in patient with prescribed for BBI. The management of BBI and the EU similar decrease in the level of this molecule were observed in population of this of the esophagus. Corticosteroid are another effective therapy in the treatment of EUE. The most commonly used corticosteroid are used budesonide, fluticasone, propionate, and silsisonide. They induce histological remission, and the dose usually 1 milligram budesonide or 880 milligram fluticasone in viscous solution twice a day. Histological remission was achieved in 90%, 93% with the budesonide versus 0 in patients with the placebo. A recent study that include 229 patients with median follow-up of 5 years found that a patient taking topical steroid by swallowing in 40% of visits, this population has higher frequency of clinical remission, 31% versus 4.5%. Endoscopic remission, almost 49 versus 18. Long-term maintenance therapy had been proposed for patients with esophageal stenosis, symptomatic relapse upon discontinuation of treatment, recurrent food impaction, comorbidity that increased the risk of endoscopy and dilatation of the previous spontaneous perforation or perforation induced by dilatation, as well as for other patients who travel where there is area of high food impaction. Side effects are candidiasis and adrenal insufficiency. The guidelines do not recommend use of leukotriene antagonists such as montoclast as induction or maintenance therapy. Monoclonal antibody agonist, mepolizumab, decreases esophageal symptomatic improvement and decrease the quality of life. Although biological therapy is safe with limited and reversible risks, it needs more investigation and study. It has been used that role of dietary antigen play and role in the pathogenesis of this disease. Currently, there is 3 choices of initial dietary therapy. 1, elemental diet. A meta-analysis found that elemental diet was effective in 90% of cases, and that they were superior to both 6-food elimination SFED, which was effective in 72%. The main limitation include poor palatability of formula, resulting in adherence by only 1/3 of the patient. Psychological and social disturbances, allergy testing guided food elimination diet. In this specific dietary approach, skin pricks test and atopy patch are performed to test for food allergen, which subsequent elimination of food with positive result. The food most commonly I defined are milk and egg. There are low concordance between the result of the cutaneous test for food allergy and the undefined EUE. In a study with which include 5 different food allergies were conducted via skin and blood test. Specific IgE, basophil activation test, and serum food specific IgG. No allergy test could currently predict the actual food triggers. A monitoring treatment system has been proposed that evaluate response along the spectrum that include complete normalization response and non-response based on histology, symptoms, and endoscopic finding. Additionally, non-invasive methods are being studied. There are cytosponge and esophageal string device, blood markers, and now I'll finish from this. I'll talk now in Barrett's esophagus. Barrett's esophagus is well established pre-malignant stage of esophageal adenocarcinoma, and defined as an extension of salmon-colored mucosa into the tubular esophagus, extending more than 1 centimeter proximal to the gastroesophageal junction, with biopsy confirmation of intestinal metaplasia. The rationale for screening Barrett's esophagus is early identification of patients who had increase of adenoesophageal carcinoma, and timely intervening with the goal of decreasing mortality. Despite lack of evidence of randomized controlled trials, indirect evidence suggests that screening lead to detection of esophageal adenocarcinoma at earlier stage, better outcome, and increase in 5-year survival rate. Better targeting of candidates for Barrett's esophagus is necessary in order for screening. Now, who should we screen? Chronic GERD should be screened because there is an association between Barrett's and GERD. Other risk factors include male gender, increasing age, white race, central obesity, cigarette smoking, and family history of Barrett's esophagus. Men develop Barrett's esophagus about 20 years earlier than women. This association persists after adjustment for the body mass index and GERD. Having the 5 risk of esophageal adenocarcinoma was 0.16 for individual with scores above the threshold, and 0.02 for individual with a score below the threshold. Careful visual inspection during EGD and 4-quadrant biopsy at every 1 to 2 centimeters using the Seattle protocol and biopsy of mucosal irrigation in salmon-colored above gastroesophageal junction is the gold standard for BE screening. Standard brush cytology for detection of BE Barrett's esophagus was evaluated. Cytology had high diagnostic accuracy for high-grade dysplasia. The addition of brush cytology complement histology and increase cost without improvement in the diagnosis. Standard EGD is expensive and associated with small risk of complications such as cardiopulmonary events, aspiration, bleeding, perforation. Unsedated transnasal endoscopy is performed with ultra-thin endoscope using topical anesthesia, obviating the need for sedation compared with EGD. The sensitivity of this procedure for detection of columnar line esophagus was 98% and intestinal plasia 91%, and the specificity was 100%. better acceptance of affordability allow consideration of this ultra nasal endoscopy. Cytosponge is mesh surrounded by gelatin capsule attached to the string passed orally. 5 minutes after swallowing the capsule, dissolve the proximal stomach, expanding the mesh to a sphere of 3 centimeters. The sample containing a cytological specimen stained with trefoil factor, which is biomarkers for intestinal metaplasia. In an area study, prototype non-endoscopic balloon with the spikes on the surface was passed transorally on patient with Barrett's esophagus presenting for a surveillance. Balloon cytology was positive in 50, almost 80%. Recently, swallowable non-endoscopic encapsulated balloon device with textured surface was developed. In 86 patients who swallowed an endoscopic balloon, biomarker panel consisting metaplasia with 90% sensitivity and 91. As there appear to be higher risk of esophageal adenocarcinoma with Tallarella forsythia and Lactobacillus fermentum, and lower risk with a fewer number of genus Neisseria and species Streptococcus pneumonia. However, the diagnostic accuracy and application for the general application, visibility and cause are yet to be determined. It needs further study. Currently, surveillance involves early detection of dysplasia by high definition white light endoscopy with random 4-quadrant biopsy. In Barrett's esophagus, on the degree of the annual risk of esophageal adenocarcinoma in Barrett depends on the degree. Virtual chromoendoscopy involve advanced imaging without use of dye, recognition of mucosal and vascular patterns, guides imaging target biopsy, leading to fewer total biopsy and reduced cost of surveillance. That's it. خلاص. Thank you.
Assalamu alaikum. And now again with Dr. Abdulaziz Al Abdulali to continue his presentation.
Good evening again. This is the second part. It's a continuation of the previous with the other issue of how to use the direct oral anticoagulants. Just to continue on the indications when it comes to DVT-PE, this is the ACCP 2021 and the ASH, American Society of Hematology. And in short, there is a preference of oral, of direct oral anticoagulants over vitamin K antagonists in the treatment of DVT or PE. In patients who are having antiphospholipid syndrome and they are in need of anticoagulation, they should be on vitamin K antagonists rather than a DWAC. Those who are having unprovoked VTE, there is a recommendation to put these patients on an extended anticoagulation rather than just the 3 months period. Patients who are having VTE in the setting of cancer, DWACs can be used over low molecular weight heparins. None of these societies mentioned which reference. Now, this is in short the 4 randomized trials looking at the use of DWAC in patients with VTE or PE. All of them, they're non-inferior, equal. Now, all of them, they're not superior when it comes to the risk of bleeding, major bleeding, except apixaban in the amplified trial. So probably this would be the drug of choice in this setting of patients. Non-inferior to warfarin, but a superior safety profile when it comes to major bleeding. In medically ill patients, the indication is, or the recommendation is to use the low molecular weight heparins rather than the direct oral anticoagulants. In medically ill with renal impairment, you need to decrease the dose of the low molecular weight heparin, the enoxaparin, but without changing the dose of dalteparin, tenzaparin, or unfractionated heparin. And it is advisable not to use fondaparinol when the clearance is less than 30. When it comes to orthopedic, they are very lucky. They have lots of medications that are approved for hip and knee arthroplasty, all the low molecular weight heparins, and the DWACs. One important point, still hip fracture, no DWACs, only low molecular weight heparins. Now, in the how to use DWACs, this is like a case highlighting the interaction with food. Elderly, diabetic, hypertensive, diagnosed with non-valvular atrial fibrillation, started with rivaroxaban 20 milligram daily. The patient is taking it on an empty stomach. 30 days later, he developed right-sided weakness, brought to ER, CT showed left MCA infarct. It's very important. Rivaroxaban 15 and 20 should be taken with food for better absorption, not on an empty stomach. The 10 is, yes, can be with empty stomach or with food. It's another case scenario with dabigatran. Elderly female, hypertensive, diabetic, high lipids, living in a nursery home, diagnosed with non-valvular atrial fibrillation, started in dabigatran, and the nurse, for the sake of help of her patients, because she's having some degree of swallowing difficulty, she was rushing the drug. 14 days later, the patient found to be non-responsive. CT showed massive intracranial hemorrhage. When the tablet of dabigatran is crushed, there's a 75% increased bioavailability. So with dabigatran, never chew or open the capsule. Keep it in its original package. Apixaban can be taken as a whole, with or without food. Rivaroxaban, the 10 can be taken with or without. The 15 and 20 should be with food. If they are taken on an empty stomach, they'll not be adequately absorbed. Some other practical issues regarding food intake, antacids, We've talked about the relation with food intake. There is no interaction with PPIs, blockers, or antacids, so it's safe to use them. No data yet on fish oil supplements. It can be given through NG tube for apixaban, rivaroxaban, edoxaban. Never ever open or crush the bigetran. These are some issues clinically with dosing error when patients are missing a dose or having a double dose or uncertain. So if a patient forgot dose, it may be taken he can take the dose as long as 50% of the dosing interval has passed. After this point, the missed dose is skipped unless high risk thrombosis, low bleeding. So you can see the issue of using DWACs is not really an easy, straightforward as it is thought to be in relation to warfarin. In case of doubling the dose, for a BID dosing, skip the next dose. For once a day, continue without skipping the next dose. If the patient is uncertain about a dose or about whether he took or not, for a BID, should not take another dose. For once a day, take another dose for a high check score. Don't take it for a low score. Drug interactions. 70 years old male with non-viral atrial fibrillation since 1 year, previous history of TIA, hypertension, started on a DWAC, which he was very religious, compliant. 2 weeks ago, complained of gastric pain, found to have H. pylori, started on triple therapy, Classed included. 10 days later, brought to ER with GI bleeding. This is interaction with Classed. It's another one. It's a case just to highlight an interaction with verapamil. The metabolism of all the DWACs, they get absorbed all through the same mechanism, utilizing a glycoprotein, B glycoprotein. It's very interesting, glycoprotein. It helps in the absorption and re-excretion to the lumen. So any drugs that inhibit this would lead to accumulation in the circulation, like verapamil, Uderon, quinine. They're all cardiac indications that atrial fibrillation patients are on. Next step is that they are excreted to varying degree and through the kidney. The most dependent on the renal excretion is the bigetran, the least is apixaban. They get metabolized in the liver, so medications that induce or inhibit Psi before 50 affect the level of these medications. And not to forget the interaction with food. Contraindications. They are taught, DWACs are totally contraindicated in patients taking strong inhibitors, B-glycoprotein, mostly the azoles or HIV medications, or strong inhibitors of both B-glycoprotein and CYP3A4, azoles, HIV, imatinib. This is a new form. They should be avoided in these classes of medications. Use with caution in these. As a help, whenever your patient is on a DWAC, always check each and every medication. Use Google. You can Google it. There are lots of helpful sites that give you the interaction. And preferably every now and then, because new information about interaction always is coming. DWACs and kidney disease. It's an elderly with creatinine clearance, 45 ml per minute, farmer living outside Riyadh, and he was diagnosed with non-favorable atrial fibrillation on rivaroxaban. Unfortunately, he is just for the ease, just can refill during clinic visits every 4 months. So life is much easier, or thought to be easier, with DWACs than warfarin. But he got progressive weakness, found to have severe anemia with hypotension. Now, patients with chronic kidney disease best to be on the least renally dependent WAC, which is rivaroxaban, which is, apixaban rather than rivaroxaban. Also, they need to be closely followed up. The guidelines is every 3 months for a normal patient. Someone with impaired renal function should be closely monitored, especially if he or she is working outside the healthcare system, like a farmer. He will be much more likely to be dehydrated with worsening renal impairment. Underdosing. The message is that there is no single dose for any drug. It is dependent on the indication, on the age, renal impairment. So this patient had a DVT, started on rivaroxaban 20 a day, 3 days developed pulmonary embolism. The starting dose is 15 milligram BOPID for 21 days, 3 weeks, then switch to 20 a day. This slide shows that there is so many different dosages per indication for each and every medication that can be affected by the creatinine clearance and or age and weight of the patient. So it's not an easy one size fits all. Now, and this is why in real life clinical scenario, you see quite a number of patients that they are underdosed or overdosed using a dose that is not as per the approved indication. And this is looking at patients, more than 5,000 patients, 12.8 of them, they're not using the right dose of a drug. And this leads to a significant increase of MI in the underdose, all-cause mortality in the overdosed patients. So they're not safe medications. Not to forget that there are other side effects highlighted here. And the issue of a patient or a patient being consistently on a drug is better than being on warfarin. It's not really a true statement. And this is discontinuation rate in the pivotal trials, 4 trials. At 2 years, the best was apixaban. It was compared to warfarin, about 8%. They stopped it. But with the other medications, it's quite high. It's worse than warfarin. Now, what about the lab tests? In short, they affect the anti-10A medication, i.e. not dabigatran. They affect the BT, but more the APTT. Also the thrombin time. This is more with the dabigatran. You need to see the level with anti-10A, but you need special calibrators. Rarely you find it in the majority of the hospitals. They are different from low molecular weight heparin calibrators. What is the bottom? BT. If it is increased, it's totally unsuitable. Don't pay attention for it. PTT, on the other hand, a normal PTT does not exclude on therapy level, but it excludes over therapeutic level, overdose. This may be helpful. Thrombin time, normal thrombin time exclude even very low level. This is also very helpful clinically. Now, when to do the measurement? There are certain times in emergencies, emergency room, to inform the clinician on recent exposure, specific assays to provide accurate assessment, and cover associated bleeding disorders. If my patient is bleeding, but the level is low, I should look for another cause. It helps in timing of procedures or surgeries. Patients with acute thrombotic event for the thrombolysis may be considered. The suspected overdose or intoxication. Now, before elective procedures, the routine measurement is not recommended. May be considered when intake is unknown, concern about impaired drug clearance, patient having renal impairment, for example, or liver. Monitoring during long-term exposure is not recommended. How to switch a patient on DWAC? You want to put him on warfarin or on low molecular weight heparin, or the other way around. So a DWAC, you're changing a DWAC to a parenteral. You do that when the next dose of a DWAC is due. Just don't take it, don't give it to him and start the parenteral anticoagulation. And the opposite scenario, the patient is on parenteral and you want to switch him to DWAC for unfractionated heparin, start 2 to 4 hours. Low molecular weight heparin when the next dose of low molecular weight heparin will be due. Now, this really, for the sake of time, it's very important. This is situations which are very common faced clinically when you're in need of oral anticoagulation together with antiplatelet, mostly in the coronary artery, acute coronary artery setting. But this is, in short, now, mostly it is a single antiplatelet with a DWAC. But for real detail, I think this should be discussed thoroughly with your senior cardiologist. Now, let's see. This is before procedure management, like a surgery or radiological intervention. Two main points is one is that trying to assess the thrombotic risk of your patient and the bleeding risk. And in the thrombotic risk, we have to stratify patients into high risk, which are these, or moderate or low. And the procedure, they are already been stratified as minor, low, or high risk, detailed all the procedures. Generally speaking, in those who require minor dental procedure, cataract or minor skin, it's likely that no interruption is needed. This is one acceptable approach, as was with warfarin. One alternative approach is to skip just one dose of a DWAC. Now, this is for moderate bleeding risk or high risk. The general rule is 2-3 and 3-5. What I mean by that, for moderate, you stop 2 days before, for high, 3 days before. Except the bigatron, if there is renal impairment, then 3-5 days. That is the same. When to start? In moderate bleeding risk, usually 24 hours. High bleeding risk, 2 to 3 days. Bleeding while on DWAC, I think this is the most, hopefully this will be the last issue, but it's very important. This is a 54 history, male, history of with ischemic heart disease 5 years ago, with cancer disease, with bleeding 1 year ago, 2 months ago, diagnosed with non-valvular atrial fibrillation on rivaroxaban. 5 days ago, had pneumonia, treated at home on pantoprazole, aspirin, simvastatin, clarithromycin, classic. There's an interaction. Last dose of rivaroxaban was 2 hours. It's very important to know when a bleeding patient took his last medication. Came to the ER, his hemodynamically unstable, hemoglobin 6, INR is 1.6, creatinine is 2. True statements. This is considered a major bleeding. Absolutely yes, on DWAC. Immediately we should stop all anticoagulants, antiplatelet. Immediately we should start resuscitation, flows back to the blood cells, correct any other bleeding disorder like thrombocytopenia. We hold anticoagulant, antiplatelet. Since he came early, within 2 hours, for all the anti-10A drugs, activated charcoal can be used, but not even with dabigatran, which is the antithrombin. Dabigatran, the difference is that you can dialyze it, but not the anti-10A. For a major or critical bleeding, we need to administer a reversal agent. In this case, the anti-10A reversals is the adixanate alpha. Always I have difficulty with this, and the activated prothrombin complex. These few flow charts summarize the approach for a bleeding patient on DUAC. And in short, there are 3 points. First of all, is it a major bleeding and critical? Major bleeding being defined as hemodynamic instability, drop in the hemoglobin more than 2 grams, or in a critical site like the brain, GI, eye. Other than that, it's not major. So immediate supportive care, as we mentioned ago, transfusion, fluids, holding all his anticoagulant, antiplatelet, trying to correct any correctable bleeding disorder, thrombocytopenia, for example. The next step, if all this did well and good. If not, then you need to administer the reversal agents. So these are 2 main steps that should be done with a patient who is bleeding on a DUAC. And these are the different reversal agents. There is one for dabigatran, one for both the apixaban, rivaroxaban. For vitamin K, mostly we use the 4-factor BCC, prothrombin complex concentrate. The next step really is to decide, should the patient be on the anticoagulation, i.e. to go back to square one, reassess your patient, the need, whether he needs or she needs other medications like antiplatelets and so on, whether this is the right type of DUAC or I can switch it because of renal impairment, the dose itself, and the time. I'll skip these. So this patient got stabilized, and when you look at his SHA-2DS score was 1. So to start with, he was not in need for oral anticoagulation. Bleeding was because of a DUAC, yes. The type of DUAC, rivaroxaban, mildly renally impaired, with a medication interacting with rivaroxaban. Apixaban probably would be much safer in this patient. So the patient, after stabilization, he was discharged on PPI and aspirin. This is at the end, so thank you so much and sorry for keeping you late.
Thanks for Dr. Abdulaziz Al Abdelali for this nice presentation. We should make it early in the morning because we have to concentrate more. And now, the best presentation we will end our webinar with Dr. Khaled Fathi. Dr. Khaled Fathi is associate professor in Shams University, and he's consultant rheumatology in Saudi German Hospital. And today, Dr. Khalid Fathi will talk about autoantibodies. السلام عليكم ورحمة الله وبركاته. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على رسول الله صلى الله عليه وسلم. It's my pleasure and honor to join you in the nice internal medicine symposium, and it's my pleasure to return back to my mother's specialty. I thank my dear brothers in the organizing committee, especially Dr. Ahmed Nasr and my dear brother Mr. Tamer, for their nice invitation, and I hope inshallah it will be concise and useful. I'll talk today about an annoying issue in rheumatology, especially for the rheumatologists. Inshallah, I hope it will be useful and concise. Rheumatology is a calm branch, a very calm branch, I suppose to be, but by time I discovered it was not. Rheumatology is more deep, more vague, and more complicated, unfortunately. Actually, I have different topics to my presentation today. You can choose as you like appropriate serologic testing to evaluate rheumatic diseases, or clinical utility of common serum rheumatological disease tests, or interpretation of investigations in rheumatic diseases, or making sense of rheumatological investigations or laboratory testing. I am sorry for this interruption. Or laboratory testing in the rheumatic diseases, a practical review, all supposed to be the same idea. Autoantibodies, the double-bladed sword. I named it double-bladed because it has a blade to get the diagnosis and another blade to harm you. You must get the useful one and avoid the harmful. ومن الشعر يعني نفس المعنى السيم ظننت بهم ظنا جميعا فخيبوا رجائي وما كل الظنون تصيب. We have a nice case, a very common case, which are consulted about. A 23 years old woman is referred to your clinic to rule out lupus, a very common scenario. No history of anything suggesting rheumatic disease, no photosensitivity, no skin rash, oral ulcers, pleurisy, hair loss, or even arthralgia. But on family history, she has an aunt of Sjogren and a cousin with lupus. Physical examination is free, and the ANA, which was requested by fault, came back positive with low titer. Does she have lupus? A common question. To answer, we'll proceed to the presentation. Inflammation is the hallmark of rheumatic disease. It is useful. God created it to promote several modifications on the head to eliminate the offending agent, to limit the tissue damage, and to restore the affected structures. We have some inflammatory biomarkers to follow up the disease and the drug. Laboratory analysis can assist us to monitor the disease activity and treatment response. We have many methods, out of which we have ESR, CRP, and to a very less extent the protein electrophoresis. These are the inflammatory biomarkers. We are not using all of these. These are the
The previous ones were the positive increase of inflammation, and these are the negative inflammatory biomarkers that decreases with inflammation. They cost much with different costing. ESR is the least, the cheapest, and the extractable nuclear antigens is the most expensive. Add to this list the synovial fluid testing. The use of testing must be used after history taking and physical examination. This is a nice table to illustrate the utility of inflammatory markers, mainly to differentiate between mechanical and non-mechanical. Mechanical, with all the inflammatory markers are negative, and like mechanical back pain, like fibromyalgia, and in contrast, the connective tissue disease with the non-mechanical or inflammatory, with all are positive. Gout in between, but it's more prevalent in the synovial fluid analysis. يعني inflammatory markers or biomarkers can guide us to differentiate between mechanical and non-mechanical issues and to monitor. The most famous is the ESR, erythrocyte sedimentation. It increases in old age, female, pregnancy, anemia, and even the increased fibrinogen infection, malignancy. As you see, it is highly non-specific. At in decrease in extreme leukocytosis, polycythemia, sickle cell disease, and protein abnormalities with hyperviscosity state. It is an indirect measure and non-specific. It increases infection, inflammation, malignancy, but it is non-specific. It can be used as a diagnostic criteria in temporal arthritis. It is useful to monitor polymyalgia rheumatica, rheumatoid arthritis. It is useful to monitor. The more specific is the C-reactive protein. It is a protein synthesized and secreted by the liver as an acute phase reactant. It is not, the role of which is not fully understood, but it seems to have a pro-inflammatory effect. The difference between CRP and ESR: CRP is quickly rise, quickly falls. It is a direct marker with high specific and highly sensitive than the ESR, and not affected by other organs. We can conclude that it is highly specific and more useful than ESR. We'll come to the major topic in our talk today, the autoantibodies, the most big one. Autoantibodies by name, it is an immunoglobulins that the body secretes in reaction to autoantigens. Autoantigens are self molecules in the nucleus or cytoplasm or the cell surface of the body, but they are associated with an autoimmune diseases, and most of which have no pathogenic role in any disease. These are the history of discoveries of such the anti-CCP in the 90s, the NK in the 80s, the CRP in the 70s, the anti-Smith in the 60s, ANA and its daughter anti-DNA in the 50s, and the elder brother, the rheumatoid factor. These are the list of autoantibodies: rheumatoid factor, and ANA, anti-DNA, anti-double-stranded, anti-single-stranded, anti-histone, anti-Smith, anti-URNP, anti-Rho, anti-La, anti-Ribose. A very long list, which must be used wisely. The American College of Rheumatology issued a nice paper as a guideline for immunological laboratory testing in the rheumatic diseases. They concluded that such autoantibodies can help to diagnose, can define the immunopathophysiological basis of the rheumatic disease, and can define the classifications. It can support the diagnosis. It can guide us to monitor the disease activity and response to treatment. It can predict the prognosis, but take care. In spite of all of which, the they have a great utility in diagnosis, but mostly they are misused, especially in non-rheumatologists. So be cautious. Improper application of such tests can result in misdiagnosis, inappropriate therapy, and unnecessary healthcare expenses. The most famous of which are the anti-nuclear antibodies. Their prevalence can differ according to the titer. Low titer are more prevalent in the healthy individuals, especially in the healthy individuals. When the titer increases, the risk, and you can imagine that high titer 1 to 160 is present in 5% of the healthy population, healthy normal population. Even the healthy relatives of SLE patients can possess a highly positive with high titer. And even in the elderly, 70% are positive with low titer. So, ANE can be positive in a long list of disease, rheumatic and non-rheumatic. You can see in all rheumatological diseases, nearly in all rheumatological diseases, with different patterns: homogeneous, speckled, anticentromere, antinuclear, anticytoplasmic. These are the sons and daughters of ANA. We call it ANA panel. It's highly prevalent, as we mentioned, in inflammatory, in infections like chronic HCV infection, even in malignancy, and even in normal population. ANA must be used wisely. Anti-nuclear antibodies directed against a variety of nuclear antigens have been detected in the serum of patients with rheumatic and non-rheumatic. They present a wide array of autoimmune diseases. When used correctly, they can be useful and provide a valuable diagnostic and prognostic information. But however, it must be kept in mind that their presence alone can neither rule in or rule out any particular disease. You must put ANA in its actual size. These are as we mentioned, in the subtypes of ANA, the ANA panel, and the diseases. The most famous of which is the SLE, systemic lupus erythematosus. And the new criteria for classification of SLE, you must start with a positive ANA. There is a strong clinical suspicion with the patient. You must order an ANA to the best diagnostic laboratory test to obtain. But ANA is present in many, as we mentioned, because that's why ANA is not used for screening, must be not used for screening, to rule out. If it is positive, you must proceed for the ANA panel, anti-DNA and extractable nuclear antigens. It has no correlation. We'll repeat this sentence in the next slides also, most of which are, there is no correlation between the titer and the disease activity. It is nonsense to repeat serial ANA testing. Systemic sclerosis, the scleroderma. If you suspect a patient with systemic sclerosis, you must order and you must have an ANA testing to support your diagnosis. Also, no correlation between the titer and the disease activity. Therefore, do not repeat ANA. Including in the ANA panel, anti-SCL70 and anticentromere can have a prognostic significance if ANA is positive. Same sentence come for the idiopathic inflammatory muscle disease, namely polymyositis and dermatomyositis. ANA, in contrast to SLE, has a weak evidence, can weakly support the diagnosis. It is not useful for diagnosis nor for prognosis. No correlation between the titer and the disease activity. Therefore, do not repeat ANA in patients with dermatomyositis or polymyositis. Same for Sjogren, the dry disease. Maybe the patient with Sjogren possibly related to SLE, ANA can help, but also no correlation between ANA testing and monitoring and the disease activity. Same for mixed connective tissue disease, ANA testing If it comes positive, you must order the RNP. It is useful for diagnosis, but not useful for disease monitoring. In the GIA, the story is a little bit different because ANA is still, in spite of being non-useful for diagnosing, but it is useful for following up or predicting uveitis. All patients with juvenile idiopathic arthritis must be monitored for ANA to rule out in the future uveitis. In rheumatoid arthritis, ANA testing is not uncommon, but the presence of which has no diagnostic significance. Again, no correlation between ANA testing and the disease activity. In conclusion, for the ANA, these are important words. Positive ANA testing is associated with a number of systemic rheumatic and non-rheumatic diseases. If the ANA test has greatly assisted the diagnosis of this, especially the SLE and systemic sclerosis, however, the false positivity rate associated with these tests limits the usefulness as a screening test for rheumatic disease. The daughter of the ANA is the anti-DNA antibodies, the most important of which is the double-stranded. Anti-DNA testing can be very useful in the diagnosis of SLE. About 60% of SLE patients carry the positive anti-DNA. It supports the diagnosis, but negative test does not exclude the diagnosis. Therefore, it is a good positive test while it is a bad negative. Anti-DNA is reserved only for positive ANA. If a patient with negative ANA, it is nonsense to order an anti-DNA. In contrast to the antibodies, especially anti-DNA correlates with the disease activity, especially lupus nephritis, the renal disease in SLE, but also to a limited extent. High titer of anti-DNA carry the strong association with disease activity, but in spite of which it does not predict the flare, and the titer can be associated with flare. We'll talk less quickly about the anti-CCL70, anti-centromere, and anti-nucleolar. They are especially anti-SCL70 is very useful in the diagnosis of systemic sclerosis, the presence of which is useful, especially to predict the cutaneous involvement and the radiological pulmonary fibrosis, the disease. Anti-nuclear is less common. Anti-centromere is useful in the crest, especially the skin involvement to predict the limitation of skin involvement to distal to the elbows. It is useful also for the pulmonary fibrosis. Anti-Smith, anti-RNP. Anti-Smith is like anti-DNA, is highly specific for SLE, but unfortunately does not correlate with the renal disease as the anti-DNA does. It is useless in lupus nephritis to monitor or predict, and it predicts the flares. Anti-Rho, anti-La, especially in the SLE and the Sjogren, also carries a less activity, but it is useful to rule out the congenital heart disease, neonatal lupus. Rheumatoid factor, about 50 to 85% positive in the rheumatoid arthritis, but alone cannot make the diagnosis because 5% of healthy population are positive. Therefore, it is non-specific. This must be ordered only when you have a patient with arthritis and cellulitis. Lastly, the anti-CCP is positive, similar sensitivity, but highly specific than the rheumatoid arthritis. This arises the importance of history taking and physical examination. اليوم حاجتنا إليك وإنما يدعى الطبيب لساعة الأبصار. I will end up with the take-home messages. Do not in rheumatology, except with the exception of anti-double-stranded DNA, do not repeat any subserologies in patients with established connective tissue disease. Do not perform serial measurements of rheumatoid factor and anti-CCP in a patient with documented seropositive RNA. rheumatoid arthritis, or serial ANAs in a patient with documented SLA. Do not order HLA-B27 unless you suspect an undifferentiated spondyloarthropathy. Do not order an MRI before ordering a plain films with patients presenting with joint or back pain. In summary, these are so important take-home messages. I hope you catch it. Good history taking and complete clinical examination are the cornerstones of diagnosis. Laboratory tests should be used to confirm your clinical diagnosis and not to make it. Laboratory tests are not the gold standard for the diagnosis of an autoimmune illness. Autoantibodies may be associated with a particular disease process. Their sensitivity and specificity vary. They are an adjunct used in combination with both the history taking and physical examination. Each rheumatic disease has a set of criteria used to make the diagnosis of that particular disease process. A lab test is just a small portion of that, not the minimum. Normal individuals may have a positive autoantibody test without any disease process. None of these tests is perfect. Therefore, selective ordering can improve the clinical usefulness and cost effectiveness of serum rheumatological tests. These tests should be ordered and interpreted cautiously and only within the context of the patient's clinical situation. We do not treat lab tests, we treat the patient with the lab tests. The practice of ordering rheumatological panel or arthritis panel is discouraged. And my final advice is do not order any laboratory test unless you know why you are ordering it and what you will do if it comes back abnormal. My take-home message: ذو الحزم لا يبتدي أمرا يهم به حتى يطالع ما تبدو عواقبه. وأحسن منها يا مقلب القلوب ثبت قلبها. Thank you so much. إن شاء الله يوفقك بالبيت. السلام عليكم.
Thank you, Dr. Khalid. There is no other questions, and I would like to extend my thanks to the organizing committee, Mr. Tamer and his team, and also thanks to Dr. Muhammad Abdullah, who helped me all through this presentation for the last 3 days. Right now, I would like to announce that certificates for the attendance will be delivered to your emails within 1 week, and also CME hours will be added within 10 days from now. For any clarification, please contact Mr. Tamer on his WhatsApp or email. Thank you for all, and thanks for the 400 people who are still with us till now. Assalamu alaikum wa rahmatullah. Tasbahu ala khair.